Good morning. Thank you, Chair. Present is Dr. Jacobs, Ms. Keller, Dr. Harvard, Mr. Trava, Mr. Dlamini, Dr. Nathan Gal, Ms. Wilson, Ms. Chirwa, and Mr. Imam Sheikh, and Ms. Sukeros. Dr. Tembekwa, you will join the meeting later. Thank you.
Thank you very much. No other able to proceed. And if I see that we have Mr. Chen and Mr. having joined, and then from the department is Mr. Hartlaw on the platform?
No, Chair, the department it doesn't form part of this meeting.
Okay. Just thanks, Ms. Jalamba. Just needed to make sure of that. And then all being this is a live streaming of the portfolio committee meeting, and therefore want to do their presentation and statements. Mr. Chen can just tell us who has joined with him this morning.
Good morning, Honorable Chair and members. I'm Head of Research and Acting my company, my chairperson, Dr. Patience Baba, as well as Commissioner is also in attendance, Rockman. I don't know if there are other commissioners, so if I may just let my principal executive authority to come through, Chair.
Thank you so much to yourself, Chen. Good morning, Chairperson, Dr. Jacobs, and good morning as well to all the honorable members. I am Dr. Mbava. I am the Chairperson of the Financial and Fiscal Commission. I am also accompanied by other commissioners who are on the platform and by the Head of Research as well. And today, the presentation, Chairperson and members, will be made by Ms. Claire Horton, as well as Mr. Sabelo Mtandato. Those are the presenters for today. Chairperson, I switch on my camera just for the members to be able to see who is on the platform. And then if you'll allow me, I would switch on my camera later on. Chairperson, our presentation today is on the submission regarding the performance of the health function, looking at all the entities of the health function. In terms of
Dr. Mbaba, just a short moment. I just wanted, sorry about that, an introduction, and I apologize for not introducing you first or asking you. But thank you very much. I couldn't see who was on the platform, you, and as a chairperson, the commissioners, and also your the presenters. I just need to do one other thing, official thing, and that's to read the rules of this meeting, and then I will hand straight back to you. Thank you. So, honorable members, just a note that this virtual meeting is deemed to be in the precinct of Parliament and therefore constitutes a meeting of a committee of the National Assembly for official purposes only. In addition to the rules of virtual sittings, the rules of the National Assembly, including the rules of debate, apply. Members enjoy the same powers and privileges that apply in a sitting of the National Assembly. Members should equally note that anything said in the virtual platform is deemed to have been said to the House and may be ruled upon. All members who logged in shall be considered to be present and are requested to mute their microphones and only unmute when recognized to speak. This is because the microphones are very sensitive and will pick up noise which might disturb the attention of other members. When recognized to speak, please unmute your microphone and connect your video. Members may make use of the icons on the bar at the bottom of their screens, which has an option that allows a member to put up his or her hand to raise points of order. The Secretariat will assist in alerting the chairperson to members requesting to speak. When using the virtual system, members are urged to refrain or desist from unnecessary points of order or interjections. Now, just to be a reminder that we have 2 hours, so Dr. Mbaba, you have at least for maximum 1.5 hours. We would still have to take questions and responses, so hopefully we'll be able to do that shorter, maybe an hour or so, and then allow us for questions and then also for answers from yourselves. Thank you. I now hand over to you.
Thank you so much, Honorable Chairperson. If I can have thank you so much for the presentation. Chairperson, I'm just going to do an introduction and then I'll hand over to the research team to take the committee through the presentation extensively and providing more insights and analysis. Just to first formally introduce the Financial and Fiscal Commission. Who are we? We are a constitutional body. We established in terms of Chapter 13 of the Constitution. Our role is to advise Parliament, yourselves, provincial legislatures, and any other authorities determined by national legislation. We advise specifically on the equitable share and allocations of revenue across the 3 spheres of government. We also advise government on government guarantees, on provincial taxes, municipal fiscal powers and functions, any provincial loans that are being considered, municipal loans as well. It's very important to note that all these legislative prescripts can only be approved or passed by Parliament after the views and the recommendations of the Financial and Fiscal Commission have been considered. Our submission to yourselves today, Chairperson, is to provide some analysis and our insights regarding the portfolio committee's oversight on the Department of Health, provincial departments and entities, and also specifically look at the annual performance plans and budgets for the 2023-24 financial year. I now hand over to the head of research to give some context as well regarding the current health issues. Thank you so much. Over to you, Chen.
Thank you very much, Chair and Honourable Chair members. Health is one of the critical importance functions, public policy as well as public value and goods and services to our people, alongside education and social developments. And it being, and depending on which level we look at, but we will look at all levels from national to provincial and to ultimately entities even in terms of the health function. And in the various spheres and levels, we see health as being significant portion, taking up significant portion of the various spheres allocations and in terms of division of revenue. And that's why health is a important vote to consider in terms of our overall fiscal framework, as well as our public service and public policy and functions. Without further ado, let me hand over to my research team to take you through the presentation today. The structure of the presentation is overall looking from the current health issues in general, in terms of services to our people, to then national departments' budgets, then provincial budgets and entities, and we will end off with our conclusion and recommendations emanating from the research that had been done on the department of, or the health function, shall I say, concurrent as this is. And lastly, I'd like to just emphasize the importance of where we look at, for example, health as a function. Yes, it's good to look forward in terms of the annual performance plan and looking in terms of the MTF as well as the divisional revenue. However, remember that the budgeting process as well as performance planning process is one that is informed by historical performances as well as financial and non-financial performances. And hence, some aspects of the analysis that we will be sharing with you today will look at the historical performances in terms of in projecting and forecasting the forward performances in terms of financial and non-financial outcomes. With that, let me give it over to Sabelo. Thank you, Honorable Chair and members.
Thank you very much, Chen, and good morning to honorable members and our chairperson and all other people who are present in the platform. Yes, what we thought we needed to do in the beginning is just to paint or to present to the honorable members the context or the current health issues and challenges so that we'll understand what the program is intending or trying to fund. So firstly, what we did here, we highlighted that we must understand the challenges within the health sector, particularly a high burden of both communicable and non-communicable diseases. And these communicable and non-communicable diseases, they need a targeted and preventative programs or approaches. And then what we have here in the figure, we've just taken few of diseases that are a challenge in our health sector and illustrate them here. And you can see the load within the health sector with respect to diseases. Particularly, you look at the hypertension or high blood pressure, you see how high it is. You look at the prevalence of the HIV, diabetes, and arthritis, and other diseases. We're just highlighting here, painting the challenges that we do have with respect to these diseases and the need to fund them and to have targeted programs. Furthermore, with respect to HIV, we are noting that there's been an increase in the prevalence of the HIV, according to the statistics, Stats SA in 2021. And the number has increased. Now it has reached about or over 2 million, that is 2.2 million people that are HIV positive. And we need to understand that this number is related to the budget. It has a direct effect or impact to the budget because these people, most of them have to live on ARVs, and then the funding will be needed to address such challenges. And then again, we're highlighting that within our health sector, there's a high level of inequity in terms of healthcare resources. And then this, again, will be addressed by a number of interventions, including the speeding up of the implementation of health reforms. And then we're highlighting here that one of key reforms that are needed in the health sector is the national health insurance. Then we need to speed it up. And then we're highlighting again that within the inequity of health resources, we're highlighting that the private sector, which has more resources because people have medical aid, and then it only covers about 15 to 16%, with the remaining of population being covered by public funds. They go to public hospitals when they get sick. They don't have access to private sector. That is over around 85% or so. Then this shows how skewed the resources are. Next slide. And here we are just highlighting the number of people or percentages of people who have medical aid versus the number of people who do not have medical aid. In South Africa, as we've indicated, that it's about 16% of people who have medical aid. Then the rest are a responsibility of a public sector or public health care. And then here we did provide a breakdown of according to ethnic groups, or on which ethnic group is more covered and which one is less covered. For example, here you see that the whites and Indians or Asians are mostly covered, and then blacks and colored are the ones who do not have medical aid, who will rely more on public funds, on public health care. Next slide. Okay, but we do note that there are some improvements within the health sector, because we've seen that when it comes to infant mortality, the death rate per thousand, number of deaths per thousand is going down. Comparing 2020 to 2023, you can see a huge improvement. And again, with respect to life expectancy, which has increased from 2020, compare that with 2023. Next slide. Okay, the other challenge that we would like to highlight or to bring to the members is that there's a shortage of medical doctors and specialists in the health sector. Here we're comparing countries, other countries with South Africa, countries like UK, India, Mexico, and Brazil with South Africa. Key to note here is that South Africa has the lowest number of doctors per patient, per 1,000 patients. For example, it stands at 0.32 per 1,000 patients compared to UK, for example, which has 3.03 doctors per 1,000 patients. And the key to note here is that the situation is worsening in SA, because if we compare the number of doctors per 1,000 patients in 2019, it was 0.79, and this has decreased significantly now, is 0.32 in 2022. Next slide. Okay, now coming to the budget itself, budget analysis itself. Next slide, you can move to next slide. So key to note here in this table are a few things. First is that the health functions allocated 308.4 billion over the MTF. And then noting that 23.4 billion is added over the MTF through the PS. And then key to note again is the largest share, which goes to the compensation of employees, which is over 62%. And then this grows by 2.2% over the MTF. And once we have this largest share that goes to the compensation of employees, it implies that less resources will be available for the actual service delivery that's supposed to happen. And then key to note again is the 8.7 billion, which is allocated over the MTF to human resource component of the human resource and training grant. But again, what is important is there to note the 26.9 billion, which is allocated to hospital systems program, of which will be transferred to facilities and to provinces that will implement the NHI, the indirect grant part of the NHI. And important to note here is that while we support this allocation, particular indirect grant through the NHI, but the Commission previously made recommendations and undertook research that showed that indirect grant it doesn't perform very well compared to direct grants. And then now we are asking again that this should be used as a last resort, while capacity is being built to lower spheres of government. Next slide. A key to note in this slide is the reduction in the total budget for 2023-24. If you compare that with the budget previous year, which is 2022-23, previously it was 64.5, and then it has decreased to just over 60.1 billion in 2023. While we also note that there is a significant decrease in the average growth rate of program 4, which is primary health care, which is negative 14%. Those are key things that we need to note here. And again, this we note that it could have impact on the service delivery itself, but also note that there's been a reform in the health sector with respect to a function that has been shifted from health to it's a support health function that has been shifted from health to home affairs. And then some of the reductions that we see here are as a result of such a shift. But again, we note that, and we need to monitor and see its impact on service delivery. The next slide. In this slide, which shows expenditure trend estimate by province, what we note here, key to note, is again that minus 14% average growth that we are noting, and again the decrease or a zero average growth of 0 with respect to the communicable and non-communicable diseases. And now we say this could have a negative impact on the delivery or on the prevention of these diseases, as we have seen the seriousness and how they are increasing. So that is one thing to note. And then the primary healthcare decreased, and key to note again here is that there's been that decrease that I've spoken about on the healthcare, which we noted the shifting of that function. And the key to note again is the last point here, that the healthcare shows a decline of that is negative 14 over the MTF because of the port health services function that has been shifted to home affairs. The next slide. This slide to note here is just some changes in the head counts of personnel as well as expenditure on the compensation of employees within the sector. Key to note is that as a result of that reform that I've spoken about, there's an expected decrease in the number of head counts between, if you can see here, for 2022, it was 1,281, and then that is decreased to just over 1,000, is 1,047. So there's a significant decrease here, which could be attributed to the shifting of that function. That is key to note. And again, associated with such a decrease is the decrease with respect to the expenditure. You compare 2022-23 total expenditure, it was 812.1 million, 812 million, and now it has decreased for 2023 to 682.1 million. And again, we think that this is as a result of the shifting of that function. Next slide. Okay, key to note again is there some changes that we've highlighted here with respect to some of the selected indicators. But to note here is that some of the targets that are set over the 2023 MTF show a significant expansion. But now the question is, are we going to achieve such higher targets given the decreasing resources that we've seen, particularly on health, on primary health? That is the question. It's good to have these targets high as they are, but again, unless maybe there are plans how these are going to be funded, and or unless resources will be used efficiently in order to achieve this, because some of the targets, for example, the healthcare facility has increased by over threefold, which is over 400 from 90 in 2021-22 primary healthcare facilities to 400 in 25-26. And then again to note is the number of primary healthcare facilities that qualify as an ideal clinic per annum, which has also been adjusted. The target is set to steadily increase in 25-26 financial year. Next slide. Okay, in here we can link this first bullet point with the COVID-19, because COVID-19, when it came, then some resources were shifted from ARV programs to COVID-19, hence there were challenges around the numbers and targeting there. But the department has set a target higher now for ARVs from, I think now it's about 7 million in 2025-26, and this increased from 5.2 million in 21-22. And again, you link this with the resources that will be needed and see if it's achievable. And then lastly, what we are doing here, we are noting that the use of pickup points for dispensing chronic medical disease, there's been a change in the target, and it's a new target, in fact, and this new performance indicator with a target of 5 million is set for 2023-24. And then, yes, and then lastly, it's just the target of maintaining or repairing or refurbishing healthcare facilities, which has also increased. And we need to understand all these revisions or increase or expansion in targets in line with the resources that have been provided. I think this is my last slide. I will hand over to you, Chairperson, to Claire to take us through to the remaining slides of our presentation. Thank you very much.
Good morning, Honourable Chair and members and all other invited guests. I'm going to take you through to start off with the various entities. The first entity is in terms of the Council for Medical Schemes. This body is established in terms of Section 7 of the Medical Schemes Act, and its objective is to protect the interests of beneficiaries, controlling and coordinating the function of medical schemes, information dissemination about private health care, and advising the Minister of Health on any health-related matters concerning medical schemes. The Council plays a significant role in supporting the department and coordinating the medical industry's efforts towards realising universal healthcare coverage. Over the MTF, the Council aims to complete a review of the prescribed minimum benefits that all medical schemes must cover, promote the consolidation of options and medical schemes, support the Presidential Health Compact activities related to the standardization of healthcare, technology, infrastructure, and architecture. Total expenditure is expected to increase at an average rate of 4.7% from 193.4 million in 22-23 revised estimate to 221.9 million in 25-26. The council collects most of its own revenue. In fact, just over 95% of its own revenue is collected through various levies from medical schemes, and 3.2% is collected through transfers from the department, and revenue is expected to increase by 4.7% in line with the planned spending pattern. To note that the budget deficit has declined from 25.2 million in 1920 to a surplus of 24.1 million in 21-22, and the budget surplus is projected to continue over the MTF, although at a reduced level, to reach 1.4 million in 25-26. The next entity, please. The next entity is the Commission for Compensation for Occupational Disease in Mines and Works. And this, in terms of this entity's activities, it's mandated to collect levies from controlled mines and to compensate lost earnings caused by occupational diseases related to cardiorespiratory organs, and to reimburse workers for any loss of earnings while being treated for tuberculosis. Over the medium term, the Commission intends to focus on improving access to services provided to mine workers, increasing the number of claims paid, and fast-tracking claim payments. The Commission aims to increase the number of benefit payments made by the Commission for persons other than pension payments from estimated 7,600 in 22-23 to 8,600 by 24-25, as well as the number of certifications finalized from an estimated performance of 13,200 in 22-23 to 15,000 in 24-25. There is a reference in the APP in terms of the submission of annual reports and annual financial statements, but there's no qualification in terms of the quality of those submitted statements. So ideally, reference should be made to being a clean audit without findings. Expenditure is expected to total 1.5 billion over the MTF and increases at an annual average rate of 6.5%. Beneficiary payments account for the majority of the budget, almost the entire budget is allocated towards the payment of beneficiary payments. The fund derives most of its revenue from interest received from investments and accounts for just over 1.2 billion of its funds over the MTF period, and 25% is collected through the charging of levies to the industry. Total revenue is estimated to increase at an average annual rate of 7.8%. Thank you. Next slide. The next entity is the National Health Laboratory Service. The service is also made up of the National Institute for Communicable Diseases, the National Institute for Occupational Health, and thirdly, the Forensic Chemical Laboratory Service. The service was established in terms of the National Health Laboratory Service Act of 2000 and provides pathology services to over 80% of South Africans through its 233 laboratories throughout the country, and plays a significant role in monitoring for TB and HIV. Performance indicators linked to the various laboratory tests turnaround times show improvement over the MTF, with the target to be reached in 2025-26 of 95%. The laboratory tests dominate the service budget, accounting for over 77.8% of the service's total budget between 1920 and 22-23. The dominance of this program continues over the MTF period, accounting for 73.8% or 32 billion of the service's total budget. Its spending will increase at 11.1% annually, on average from 8.3 billion in 22-23 to 11.4 billion in 25-26. Due to the projected increase in test volumes, other than COVID-19 tests, as services start to normalize once again. The National Institute for Communicable Diseases, housed in the Surveillance of Communicable Diseases Program, is responsible for disease surveillance, specialized diagnostic services, outbreak response, public health research and capacity building, and is allocated a budget of 1.5 billion over the MTF. The service generates the majority of its revenue through the sale of goods and services. In other words, the fees that they charge for performing laboratory tests, and accounts for 88% of its total revenue. And this is anticipated to grow by 10.1% over the MTF, increasing its share of the total revenue collected to 92.4%. Total revenue growth at 6.2% has historically lagged expenditure growth at 10.2% between 2019-20 and 22-23, resulting in a sharp decline in the surpluses by 60.5%. And the surplus is anticipated to increase once again over the MTF period by 6.6% to reach just over 80 million in 25-26. The next public entity is in terms of the health standards compliance, the Office for Health Standards Compliance, and this was established in terms of the National Health Amendment Act of 2013 and is responsible to monitor and enforce the compliance of health establishments, both private and public, in terms of prescribed norms and standards, so as to promote and protect the health and safety of users of health services. Over the medium term, this office plans to increase the number of health establishments that it inspects and certifies for compliance with norms and standards. The percentage of public sector health establishments expected for compliance with norms and standards will increase from 14.5% in 21-22 to 18.4% in 25-26, as well as the percentage of private sector facilities being inspected has now been extended and is anticipated to reach 21% by 25-26. The target for the percentage of user complaints resolved through assessment within 30 days of receipt of a response from the complainant and or the health establishment is projected to increase from 26.7% in 21-22 to 75% in 24-25. To support this work, allocations to the Compliance Inspectorate account for an estimated 35.7% of the MTF budget, or 182.1 million, and grows at an average annual rate of 2.8%. The budget allocated for administration accounts for 42.5%, increasing by 7.2% over the MTF period. Total expenditure is expected to increase at an average annual rate of 4.9% from 157.5 million in 22-23 to 181.7 million in 25-26. This office is fully funded through transfers amounting to 516 million over the MTF period and will increase in line with plan for expenditure. The next public entity is the South African Health Product Regulatory Authority. To note that there was a decline in performance against a number of indicators for 2021 and 21-22. For example, the percentage of new licenses finalized per year that are related to good manufacturing practices and good wholesaling practices, showing the sharpest declines from 77% in 1920 to 42% in 2021. To improve efficiency and enable access to medicines to be rapidly scaled up and improving timelines for scientific evaluation and clinical trials, the authority plans to upskill personnel through talent management and recruitment expertise in core areas. The number of personnel is expected to increase from 292 to 331. And as a result, one will see an increase in terms of a compensation of employees, which is expected to grow from 210.6 million in 22-23 to 286 million in 25-26. There's a projected reduction in expenditure in the Health Products Authorization Program at an annual rate of 8.2% over the medium term, and is due to revising and reviewing the various business models to reduce unnecessary bureaucracy and delays. The revenue and expenditure is expected to increase at an annual average rate of 7% to total 1.2 billion over the MTF. A deficit of 13.9 million is also projected for 23-24, after which the budget remains balanced. Almost 55% of its revenue is derived from fees charged for services rendered, 40% from transfer payments, and the remainder is from interest revenue. The last entity is the South African Medical Research Council. This entity is responsible for conducting research and medical innovation in terms of the amended South African Medical Research Act of 1991 in order to promote and improve the health and quality of life of the population. The number of published journals articles by first or last affiliated author, grant holder, with acknowledgements of the council, etc., has the risk of leading to double counting. It's just in terms of the way that the various performance indicators have been captured and phrased, that there's the risk of potential double counting of performance indicators. There's a continuation of the downward trend in the number of accepted and published journals, articles associated with the council. So if one looks at the targets that have been set, one sees that historically the number of articles related to the council being published was higher than the targets being set for the MTF period. The budget over the MTF is projected to increase at an annual average rate of 0.7% from 1.4 billion in 22-23, revised estimate to 1.5 billion in 25-26, or just over 4.1 billion over the MTF period. Of this, core research accounts for the majority at 50.2% or 2.1 billion, of which 1.2 billion is earmarked for university research-related programs, 69 million for self-initiated research projects, 18 million for TB research, 15 million for COVID-related research. Innovation and technology projects an estimated 1 billion or 24.8% of the budget over the MTF. The focus is on building capacity in low middle income countries to produce mRNA vaccinations, scholarship funding to build a vaccine manufacturing workforce, tracking COVID-19 viral RNA in 80 wastewater treatment plants to enable early detection. The total revenue is expected to increase at an average annual rate of 3.3%, and the majority of funding are sourced from transfers from the department, accounting for 2.5 billion or 60% of the council's revenue over the MTF. The council also has research contracts with various international donors and other funders, which also accounts for quite a large share of their revenue that they derive, as well as interest earned, accounts for the remainder. The next section is looking at the estimates of provincial revenue and expenditure on health. And the first slide, the next slide shows just a breakdown in terms of the formula.
Ms. Horton, just a moment. Is it on my side that you fading, or honorable members? Is that with everyone? Continue, Ms. Horton. I don't get any response.
Thank you.
Ms. Continue.
Thank you, Chair. I'll sit a bit closer to the computer. I hope this assists. Chair and members, honourable members, and the next slide just provides a breakdown in terms of the funding formula that is used for providing funding to provincial health departments. And I'm only raising this in the sense that the formula has undergone quite a significant change, which was introduced last year in the 2022 MTF period, and represented the first update of this formula, this component of the PES formula, since 2010. And it had not been updated since 2010. This year represents the second year of the phasing of this formula, with the next MTF period being the last year of the phase-in. And it's just to illustrate how the formula has been updated. The old formula is on the left and the new formula is on the right-hand side. The weighting of the risk-adjusted component of the health formula remains at 75%. The formula is comprised of two components. 75% is allocated to a risk-adjusted formula, with the remaining 25% split between primary healthcare and hospital care is linked to workload measurements measured at the provincial level. And just briefly, the formula, 69% of the weighting is given to age and sex, given that actually the demand for healthcare is very much related to the age of the population as well as the gender or sex of the population in terms of the demand for various healthcare services, with the young in particular demanding healthcare services quite extensively, as well as the old, and obviously women during childbearing ages would also make greater use of healthcare facilities. There's also an element attached to total fertility rate, given the significant costs of maternal healthcare. Premature mortality is given a weight of 12%, and this just tries to be a proxy to measure the burden of disease in provinces. There's a sparsity index, which has been weighted 11%, and its intention is to try and capture some of the cost disparities or differences across provinces in terms of provinces with lower density or fewer population tend to have higher costs of service delivery. And then the last component is given a 5% weighting is the multiple deprivation index. And it actually tries to measure the difference in social determinants of healthcare across provinces by looking at the state of living conditions and education levels across provinces. Thank you. The next slide just basically shows you what the impact of the update of this formula has been on the individual provinces. And you will see from this, this slide, if you just look at the difference column, in particular, Gauteng and the Western Cape have been negatively impacted in terms of the new formula, with other provinces such as Limpopo and the Eastern Cape being beneficiaries of the updated. Given quite the large extent of the impact of this formula update, it is phased in over a 3-year period. Thank you. This slide basically is just illustrating across provinces for the years 2012-13 up to 22-23 in terms of what proportion provinces are allocating of their PES formula to healthcare. I think it's important to note, obviously, provinces have discretion in terms of how they allocate their available PES between the various funding priorities in provinces. But all this is trying to illustrate is that a significant number of provinces are actually spending more than the notional 27% on healthcare, indicating that healthcare services are under funding pressure across a number of provinces. Thank you. Okay, this is just a summary in terms of the conditional grants. Obviously, conditional grants play a critical role in the funding of healthcare services. And try to take into account the disparity of the health facilities across provinces. Obviously, not all provinces have access to or the same number and level of tertiary or sophistication of tertiary healthcare services, and conditional grants try to compensate for that and also take account where people need to make use of specialized healthcare facilities in other provinces. So overall, over the MTF period, the conditional grants grow at 1.5% over the MTF period. And this is just a breakdown in terms of the individual conditional grants. As already mentioned, there was a decline in the district health program grant. Okay. The next slide is just basically summarizing a lot that has already been said in one way or other. The health function has been allocated 809 billion over the MTF period. 23.5 billion has been added over the MTF through the PES formula to help address service backlogs, alleviate funding pressure in healthcare personnel, healthcare service backlogs, including antiretroviral therapy and TB, medicine, laboratory services, medical supplies, and other key goods and services. These have arisen partly from budget reductions following the pandemic-related economic downturn. And I think it's important, obviously, in terms of what Chen mentioned earlier, the healthcare budget would have been very susceptible to changes given that there was a need to resource it to deal directly with the COVID pandemic. And there's now a trend towards a normalization of the funding streams for healthcare. Additional funding is also allocated for the 22-23 public service wage increase and is carried through costs over the MTF period. However, these provisions were not based on the recently announced wage agreement and will place the health budget under severe pressure. Funds totaling 349.7 million in 23-24, 432.3 million in 24-25, and 568.6 million in 25-26 are allocated to the National Health Insurance Indirect Grant to enable the construction of the Limpopo Central Hospital in Polokwane. Conditional grants account for 89.2% or 169 billion of the department's 2023 MTF period. The next slide, just in terms of the budget facility for infrastructure funding within the Health Facility Revitalization Grant has been rescheduled with a net increase of 629 million brought forward over the MTF period. District Health Program, which is for HIV, TB, malaria, and community outreach, has shown a decline from 29 million to billion to 26.8 billion, or a decline of 7.6%. And as been mentioned, raises concern in terms of the funding of HIV/AIDS and provision of antiretroviral treatment and home-based care. Lastly, in terms of the recommendations, the recommendations that the FFC submission on the 2023 Division of Revenue Bill and the 2022-23 Second Adjustments Budget Bill are still applicable in terms of the Commission notes with concern a 7.6% decrease in the district health program in 2023 and recommends that the Department of Health should indicate how these reduced resources are likely to affect service delivery and how this tighter budget would be managed, especially given the expanded scope of the district health program. Also, in terms of the recommendations made in the annual submission of 21-22, in terms of the need to prioritize the development of an integrated national information system of patient and doctor registries with real-time data to enable this information to inform various healthcare financing and provisioning decisions using the demand-based costing methodology. And lastly, in terms of the need to re-examine the prescribed primary healthcare package based on the needs of people by refocusing in terms of from informing, promoting, identifying, facilitating, and educating activities to provide healthcare services. Thank you very much.
Thank you so much, Chairperson of the committee. Over to you.
Thank you very much to all of you, Dr. Baba and your team. We really appreciate you coming to this presentation. There are quite a number of points which have been raised. I think firstly, for me, is the concern about how non-communicable diseases rising at the moment to the levels which you had mentioned in your one of your first slides, and I think that was in slide 4. So it is a concern that hypertension is that high, for example, compared to diabetes and arthritis for that matter, compared with HIV/AIDS, etc., and TB. So that is a major concern, and the question would of course be how are we actually going to change the way that we look at allocation of resources to those important diseases. But I have a number of other issues which I'm going to raise a bit later, once I've given the members an opportunity to raise any questions with you. I see the hands of Honorable Gela, Clark, and Wilson in that order. Thank you. Honorable Gala, followed by Honorable Clark, and then Honorable Wilson.
Thank you very much, Chairperson. Let me welcome the presentation from FFC. Chair, I've got only 2 questions for this presentation. First, Chair, I just want to check, Chairperson, what kind of support or intervention are being put in place to ensure that the targets on ideal clinic status are improved by 2025, 2026 as reported. My second question, Chair, it's regarding the decline of entities, especially my focus will be on SAPRA on slide 21. I want to check what is the plan put in place to improve the status of declining, and also we want to see a progress because we can't allow a decline, especially in that entity. Last, Chair, it's about the HIV and AIDS. Also, one of their slides, they indicated that it's also declined. So what is the mechanism to make sure that it's not declining, and also they get those people who maybe default not taking their medicine? And I want to check, Chair, also how far they are in terms of injectable ARV, because I saw in one of the article, the injectable ARV, when it's going to be implemented, so that at least we manage, and also the issue of people who are defaulting, not taking their medication or not going to the clinic because of various reasons. Thank you, Chair.
Thank you, Honorable Gala. Honorable Clark.
Good morning, Chairperson. I've just put my camera on to say good morning, but we have load shedding, so I'm going to switch off now just to spare some bandwidth. Chairperson, I would like to just ask the following questions. Firstly, number 1, how much of the 809.4 billion from PES will be prioritized to address staff shortages, and what is the allocation per province? I just also wanted to get clarity from you, from the presenter. The numeration costs for the 295 Port Health Services to Home Affairs, has that money been reallocated to Home Affairs, or does this stay within the health budget? And if so, how has it been allocated? And then regarding the National Health Laboratory Services, what percentage of the budget is targeted towards maintaining medication, substances like antivenom, and how has the allocation increased or decreased over the past years? And then in terms of SAPRA, regarding the sharp decline in licenses finalized, how has the new business models been communicated to the applicants, and how will this impact appeals? Then I note that diabetes is the 3rd highest disease in that table that was presented to us. Now, previously I did ask the Minister in Parliament, how do they use the sugar tax that's levied in order to combat diabetes? But I didn't really get an answer in terms of that. And do we use the huge amount of sugar tax that we raise in order to put programs in place in terms of diabetes? Then also, I note that 13.7% increase in HIV, and what programs are we putting in place to ensure that we mitigate this growth? And then, the presenter did say that we should speed up NHI. So I want to know, how are we going to improve the health sector environment to ensure that we have an environment that we practice in so that we can supply quality healthcare to South Africans before NHI is even implemented. Then the figures that were shown to us in terms of how many people per race sector that belong to medical aid, were very interesting to have those raw numbers, because raw numbers speak a far greater picture.
We cannot hear you, Honourable Clerk.
Sorry, can you
Honourable
hear me
Clerk,
now,
can you
Chair?
restart? Honourable Clerk, can you restart that question?
Okay, can you hear me now, Chair?
Yes, we can. Thank you.
Okay, sorry about that. We have got load shedding, so is a problem, yeah. You know, in terms of the percentage that was shown to us in the slide as to how many people are on medical aid, it would be very interesting to have the raw numbers in terms of the percentages, because I think that would show us a far better picture as well. And then, you know, in the slides, we were told that, you know, we're sitting with such a huge shortage of doctors. And I would like to know what the department is going to be doing in order to retain our skill shortages in terms of medical doctors and nurses if NHI to be implemented. Because, you know, when you speak to the medical sector, you're hearing that doctors are going to be leaving this country if that happens. So, I mean, there must be some kind of program to put in place to try and retain our skills. And then the OHSC, you know, obviously their budget has also declined. And I would like to know how you know, whether the funding that's being put in place is able to capacitate the OHSC to ensure that state hospitals all align to the ideal clinics document that's been put in place and the requirements of NHI, because, you know, before we've discussed this, and that seems to be a real problem, that we actually don't have the capacity to do that. And with the budget declining, would we be able to sustain what is required from us in terms of NHI requirements? And then one of the recommendations was to prioritize and integrate data systems. And I agree 100%, that's a huge necessity within the healthcare system. And I mean, how long do they anticipate that this would, you know, the length of time, how long it's going to take to do this, because that's a real issue that we need to address. Thank you, Chairperson.
Thank you, Chairperson, and good morning to the Chairperson, Barbara, Mr. Chen, Claire Horton, and Mr. Mtantatu. I hope I pronounced that correctly. Thank you very much for the presentation this morning. My colleague has covered a lot of my questions. There's a few I'd like to just add on. The first one was your slide 4, the communicable and high non-communicable section, where you deal with hypertension, AIDS, diabetes, etc. What I see is not there, and it's very concerning, is the cancers. Now, we are seeing an escalation in cancers across the board at quite astronomical levels, and this has been confirmed by the Medical Research Council that, in fact, cancer is on the up and up, and I see it's not recorded there, and I think the numbers there would be quite substantial. And I raise this and the fact that it is not there, because that is one of the biggest problems we are having across the board in the country at the moment, is lack of facilities to deal with cancer patients. There's no facilities for them to go to. And I give Limpopo as an example. There's only one cancer department here in Polokwane to deal with cancer patients, whether it be radiation or chemotherapy. And we have people having to travel up to 400-500 kilometers to access those facilities. And it's very concerning by not recognizing that there's a problem, and number one, and number two, making facilities available for that people. You're principally giving people a death sentence. I think we all know that if a lot of cancers, if treated early, can be sorted out and you know, give a much longer lifespan to its victims, and that is not there, and that's concerning. I do believe that is something that needs to be looked at quite urgently. With regards to national health insurance, and my colleague just raised this, where you raise the percentage of people who are currently on medical aids. And I think, yes, I think we need to see these numbers, raw numbers, in clean numbers, how many thousands of people are on medical aid in each of these sectors, particularly given the demographics of the country, because I think that would create a far more realistic picture of where we're at in terms of medical aids. On your slide 10, it was number 3, the health, section 3, health function expenditure. Nowhere in any of your slides is there any mention of how much is being spent on medical legal claims and the legal costs associated thereto. Now, it's not a line item you can budget for. It's basically, I suppose, a contingent liability. The fact remains is that when medico-legal claims are lost, and in this country we lose, the health sector loses more medico-legal claims than it actually wins, that money has got to come out of one of those line items. And when we were on oversight in the Eastern Cape not so long ago, that was one of the biggest complaints from the hospitals, is that they have no budgets available to do what they're supposed to do, because they keep losing money to medico-legal claims, and that the provincial departments take the money on the losses of those medical legal claims out of their budgets, and therefore they can't function. And I think that's a huge red flag. I think it's something that we all need to assess very, very quickly. So, it's while the budgets look bad in— Sorry, I've lost you there. Am I back, Chair?
Yes, you're back. Please continue, Honourable Wilson.
Thank you, Chairperson. So, budgets are declining, this we know. The health sector has got a major problem already, this we know. But the situation is a lot worse than it appears to be on paper, because the money for these medico-legal claims has got to come out of somewhere, and it's got to come out of the health budget. Apart from the claims themselves, the legal costs are astronomical. And when you're sitting on 120 billion rands worth of medico-legal claims in a country that is higher than your actual budget is, we must be concerned that we've got a serious problem. The reduction in primary health care. Well, quite frankly, I think primary health care must be the most important of all the functions in health. Getting the primary health care right is we should be preventing. Our aim should be to prevent problems, not to have to cure them. And when your primary health care budget suddenly starts reducing and is not being maintained, you are creating a problem further down the line, where you now have to cure as opposed to prevent. Primary health care is critical. It's absolutely critical, and the reduction in primary health care is of huge concern. In slide 11, the departmental performance so primary health care facilities reported implementing the program. Reporting is one thing. What evidence is there? Is there evidence that they are implementing? And if so, could somebody tell us exactly where this is being implemented, so we can go and oversight and have a look at that, because I think possibly there's a degree of people being misled here. Slide 15, poorly maintained health facilities has been identified as a challenge. It's not a challenge, it's an absolute disaster. The conditions of most of the public health facilities that we've done an oversight through in recent months, it's deplorable. And our trip to the Eastern Cape was an example of that. We've never seen anything so deplorable, disgusting, and so filthy in our lives. We walked out of there very, very depressed. And again, the excuse was that medico-legal claims had a part to play in this. Some of those hospitals are not just badly maintained, they should be shut. They're in a dangerous condition. But so what are we doing about it? And quite frankly, there's a lot of talk that the National Health Insurance will change that. Well, actually, it won't. It's not going to change anything. And I think people must realize that that section of the National Health Insurance will not be implemented for several years to come, even if the NHI is passed in this term. And the Office of the Health Standards Compliance, and this is a concern for me, that they're only going from 14.5 to 18% inspections. This is abysmally low considering the state of public health facilities. And the NHI is very, very clear that nobody can be part of the NHI program until such time as they comply with certain regulations. Quite frankly, I haven't seen one that will comply in the last 2 years. So that is a problem. I'm very pleased to see on your risk-adjusted index that you have put in premature mortality and the fertility rates. We're seeing masses of teenage pregnancies, which is becoming alarming. But we also know that a lot of our medico-legal claims are linked to premature mortality and death and damage to children at birth. So I'm glad that that is there. And then principally concerns about the decrease in the district health program. This will severely affect already abysmal performances out in the poor and rural areas, where there are no resources, where they're understaffed, where they're under-equipped, where buildings are collapsed. And lastly, the changes to the health provincial allocations. 23.5 billion being added sounds very good, but how much of this would not be utilized correctly or where it should be, because they are going to end up paying millions or billions in medico-legal claims. So thank you, Chair.
Thank you very much, Honorable Chirwa.
Thank you very much, Chairperson, and greetings to all the colleagues. And thank you to the FFC for their presentation. These are my questions. I just want to have clarity on the ratio of life expectancy improvement, particularly from 2016 to 2020, because you've already given us 2020 to 2023. I just want to see that contrast of the level of improvement. And secondly, I'm concerned about the FFC's sentiments on their eagerness for the NHI to be implemented, and that's particularly for the following reasons. In the NHI, we've got what we call the referral system that subjects people to their nearest point of health facilities. Now you can just somewhere make up what that necessarily or what that necessitates. For persons living in township and rural areas, they'll still be subjected to the public healthcare system because there aren't enough private facilities in those particular areas, right? Eastern Cape being an example of that. So in terms of access, there's many areas, remote areas that have a concentration of many poor people that won't necessarily be affected by the implementation of the NHI. And the FFC is not touching on this particular thing. Now, this is important because we're also speaking on issues of access when we speak about healthcare. And if people are living in township and rural areas, if their lives won't be changed as much in informal settlements because they don't have these private facilities that everybody's looking forward to in anticipation, it should be something that the FFC particularly raise as a red flag, because it will impact the issue of access. And second to that, the NHI doesn't speak on the development of infrastructure of public facilities. And that is a problem because even the FFC acknowledges the DK and all of those things. Those things are not going to be addressed with the NHI. And the budget for those things will then be plumped into the private sector because the private sector won't necessarily wake up tomorrow morning and start prioritizing life or the well-being of people. The primary concern or the primary goal will still be profiteering. At the end of the day, it is the fact even today, it will be the fact even during the NHI. You go to a private facility today with a light headache that needs just Panado. Next thing you're waking up in a surgery room and all of those things. Because the primary motive is profiteering. We can't replace the integrity of the private sector by flooding our people into that particular issue, unless we're speaking issues of nationalizing the private sector of healthcare. And thirdly, on the issue of increasing personnel in the public sector, now this won't be done through the NHI as well. There's different systems, there's different bodies that are going to be established, but they won't necessarily deal with the issue of shortage of nurses, deal with the issues of shortage of doctors. Now, take this particular comment in reflection of what I said about the referral system, which would mean that, the township and rural areas and informal settlements will still be concentrated in those particular areas and facilities. And thirdly, I wanted to ask the FFC about, I'm concerned about the CMS and its jurisdiction over medical insurance, low cost benefit option. And it comes up many times. Firstly, on how they prioritize the medical aid industry over the medical insurance industry. And second to that, there was a continuous issue that has been raised in this portfolio committee, I think for 2 years now, on the issue of the CMS wanting a low cost benefit option to be discontinued in anticipation of the NHI, but medical aids remain. In the interest of this being obviously big industry players with their own financial muscle of that sort in the billions, up there in the billions, this is something that we're not looking into enough. And I think I want to hear from the FFC what that analysis will be like. You don't have to expand on this particular question today. You can give me a written response later on, but it's something that we've raised in this portfolio committee numerous times. For instance, even when they were trying to discontinue low cost benefit option, we would raise it, then they would extend it, because primarily they would note that what we are saying is actually true, especially noting because even in your depictions, and I forgot which slide it was, where you're showing us the number of people that are using, or the percentage of people that are using medical aids with demographics. If you look at medical insurance, it's another story altogether, and we don't have that picture because it was not presented to the committee. So even things like that show you that there's a whole industry that is under the jurisdiction of the CMS, but doesn't get as much attention. In fact, there's a bias in favor of medical aids because it is a competitive industry, and medical insurance is growing, and it particularly benefits people, the working class. So your petrol attendants, your domestic workers who don't afford medical aid but can get medical insurance and still get their GP visits and still get their medication, stuff like that. I think the FFC is in the know of how medical insurance works. And then fourthly, I want to know of the the immediate tangible threats of access to quality healthcare in rural and township areas. You've given us an in-depth presentation on the challenges and all of that, but I would like to know what are the immediate threats that this portfolio committee can take up in the immediate, through oversight, through seeking accountability from the minister and department, and through follow-ups. What are the immediate threats to access to quality healthcare in those areas? And lastly, I don't think we are experiencing a decline in entities. We are experiencing a gradual collapse of the public healthcare sector. That is the bigger picture. That is the bigger issue, and that's how it must be defined, because that is what it is over the past years. This is literally the report that we receive each and every year in and year out. We hear that the entities are doing worse and worse and worse. Maybe there'll be one improvement in one of the entities every year, but then the general progress of them is that they're going down. Same with the NDOH. Things are worse now than they were 5 years ago. Things are worse now than they were 10 years ago. Things are worse today than they were yesterday. That is what characterizes our healthcare, our public healthcare sector. And I think the FFC has such a big duty to characterize this gradual collapse of the public health sector exactly as it is, and not sugarcoat it or minimize its impact, because it is the effects of that collapse are riveting, and the deciding factor of whether people stay alive or die. And its consequences are very dire. So thank you very much once again to the FFC for their presentation. It's always good hearing from you guys and the sister committee in the work that we are doing. Thank you.
Thank you. Honorable Dr. Nothnagel.
Thank you very much, Chairperson, and thank you also for the presentation. I'm covered with most of the questions that the previous members asked, but I've got one concern about on point 6 on the slides, the South African Medical Research Council. I see there's a downward trend in the number of accepted articles with the council. If there could be an explanation for this, because we also need research, is quite an important point in this presentation. Thank you very much.
Thank you very much, honorable members. I'm also going to keep my video off for the moment, also because of bandwidth not being that good. Just a reminder to yourselves and to the FFC, we understand that you are not the department. We understand you are not going to be able to answer questions which relate to the department. And then secondly, you are the Financial and Fiscal Commission, meaning you have a particular mandate, and I think we should try to direct lots of what we talk about towards what your particular mandate is. So I do not necessarily expect you to answer questions which really relate to the department or to the entities, except for what your particular mandate is. Now, I have a number of things I want to raise with you, and it's good that you've raised a couple of concerns and a couple of recommendations, and that you've also tried to raise the things which you think were relevant in terms of your mandate. First is shortage of doctors and specialists. It is a serious challenge, I would think, in particular, considering that the population is growing. And very worrisome to see that we are at that low rate of 0.32 per thousand. Mexico, many other countries are, of course, much higher than what we are in terms of the number of doctors per thousand patients. But also concerning is, I see you noting that the number of posts, I would assume the number of posts you're talking about would be at NDOH, a decrease of those posts, and it seems to be more at the lower and the mid-level salary levels, and it's something for us to really note. The foundation of healthcare service delivery, of course, should be primary health care. And I note a particular decrease of 14% over the MTEF. And it is something that we should be concerned about. And that maybe is the reason why you've made a recommendation that there should be movement from preventative strategies to provisional service delivery, which is a catch-22, because really prevention is better than cure, and we should look at how we are going to be able to do disease prevention in South Africa, and whether we'd be able to actually improve that and put an emphasis on that, and what those manners would be in which we should approach it. It would really be very important for us to have a discussion on this particular matter of primary health care, services delivery, and prevention of illness and diseases at the primary health care level. Then you've also mentioned the fact that the PES formula for providing funding to provincial departments had not changed since 2010. And it's also something that we should note in particular as members of Parliament of the Portfolio Committee on Health. I also agree with you very strongly on the integrated national information services that is required. And we would hope that at some stage there would be a strong movement towards it and implementation of it, so that we are able to follow our patients between provinces, between towns, etc. Just noting the referral system that has been mentioned earlier, it would really facilitate easier referrals, quick referrals, and also for the healthcare workers to be able to not repeat, for example, tests, full blood counts, UNEs, and those type of electrolyte tests, etc. We need to be very, very careful that we do look at the implementation of that integrated national health information services. And just a couple of questions. Maybe this is where your mandate really is. How has the health funding kept pace with inflation over the years? Should be able to, and if not now, maybe you can write and just answer this question. And do you actually have an estimate of health inflation in the public health sector, which we know is a different basket from that of the CPI? So also, I know also a very difficult question. Would be good if you'd be able to provide some insight into that. And what do you think as the public health system, what efficiency measures could be implemented by the public health system to get more, more out of this, let's call it more bang out of what we do in terms of providing services to our people in terms of the health sector? Thank you very much. I think those are the questions which have been asked by the members and myself. I'm going to hand back to you, Chairperson, if you can please maybe assist us, and we would take this from there. Thank you, honorable members.
Thank you so much, Honorable Chairperson, and to the members for all the questions. It's always a pleasure engaging with this health committee. Chairperson, as you have rightfully said, our analysis today is essentially to capacitate the committee to enable your good selves to be able to do your oversight work, to have the tools and the information that you need to hold the executive accountable, and to hold the entities accountable as well. So some of these answers will come from the entities themselves with regards to their performance and regards to the plans that they have made and how far are they in terms of achieving those plans. We will also be able to answer some of the questions from Honorable Chira in writing as well, to answer yourself, who can do that. I wanted to ask if the researchers will have more in-depth answers as well, and then the other commissioner who's on the platform as well, before I hand over to yourself. Chen, some of the questions, especially the technical ones that we might have information on.
Yes, thank you very much, Chair and Honourable Chair members. It's indeed always a pleasure as you have touched on various key points. If I may go in reverse, Honourable Chair, about the health funding and or health cost inflation, I just quickly went on the Statisa website in the latest March that it does. It's fluctuating around on the medical products, health medical products in specific is 4.5% in the last year, and the medical services 5.5%. But I think what is missing here is when we look at these baskets in specific, it's always somewhat diluted, or it's influenced also by many of the other real essential items of inflations, food, even transports, and those other, they are integrated and interlinked, and inflation and health service, like many other services, it cannot operate on its own. So I would say that it is an indicator that's always monitored, but it needs to be monitored in relation to other aspects, important aspects, especially like Honorable Chair was saying regarding access, which I'll go into a little bit further as well. In regard, I really must appreciate, Honorable Chair, your points regarding the integrated information systems and all the other aspects referring to, including, again, the referral system, the fact that there are less doctors per person, and South Africa is a big place. So it's important to take that sparsity and as well as location, density, demand, density, I should say, for healthcare services, and that is all of those decisions, whether what kind of healthcare funding or how much to go where, and in terms of what items and or supports to make sure there is healthcare access. That all requires information, and information is what I think is overall very much lacking in this in terms of South African healthcare system. And many a times, I'm sure I'm not the only one, when we walk into any hospital across primary, secondary, or tertiary, you spend actually the majority of your time getting your patient history down, and there just seems to always be that gap of information that needs and that takes up, I believe, way too much time. And also learning from other international examples where NHI is rolled out, one always sees that there is that system that immediately kicks in when you enter or when you access healthcare. It's because it's got that economies of scale benefits, but when it's done right. And I think in South Africa, I mean, we have seen, or we have spent a lot of money, allocated a lot of money dedicated to this information system, but I don't think we see it in the implementation, and also in perhaps in aiding, assisting you on your oversight duty, is that when visiting these hospitals, it's important to look at that patients and doctors, nurses' records. Is it linked? Is it integrated? Is it able to track patients and doctors and especially patients to obviously to build that sort of medical healthcare profile, so that when the person is, say, moved from point A to B, or finally reaching, after various obstacles of referral systems to get to the tertiary, and then it doesn't take another 2, 3, 4 days for emails to come through with your medical aid, if you're lucky, or if not, your medical history from the other facilities. And so I think these somewhat logistical, right, in terms of definitely a lot of opportunities to make more efficient and effective and system informed by this integrated system of data and information. Access is always a big problem, and we believe that this is why FFC, through our research, always from a very early stage, actually, even the concept note of the NHI raised that question, that our concern regarding that data, the patient, we call it the patients and doctor trace registry. I think with regards to the other issue of performance and as well as funding allocations, I think honorable chair members will recall that in previous engagements with yourself, good self, is that FFC, we were concerned with this. There seems to be that uncertainty with the trade-off, where quality and quantity of facilities as well as services are concerned in terms of health. And we see that, right, in very sort of very simplistic way, albeit I think inside, of course, there's the reality always to do with anything real, or in economics, or we call it quality. It's much, much worse always. And and in the sense of the facilities, one can definitely see that. It's that we in attempt to try and create all these facilities, and and definitely money was dedicated to that effect in the past few years and decades, but we just did not pay enough attention, or the approach was incorrect, and in letting the quality to decline of these facilities. And that's where it shows up in terms of the ideal clinics, What to do in terms of immediate? I think apart from, of course, the information has to come through in terms of these hospitals and these clinics, but I think more so is to tie that in with the monitoring of the hospitals' budgets, which admittedly, Honorable Wilson is correct. We looked at the departments both at the national, provincial, and even at the entity level, but hospitals, especially with health, it's a very hospital-driven or facility-driven, or in some cases, people like to call it, maybe our accountants like to call it the business units-driven sector. And it's the budgets of those hospitals ought to be very detailed and delved in and analyzed. And of course, we'll then look at, for example, that the medical claims, legal claims issue at the hospital level. Now that is the micro level. Let me go a little bit on the macro, which is the question, Honorable Clark, regarding the tax and COE. The trouble, and also with other issues like PES allocations, the trouble with especially these kind of, we tax and we dedicate or allocate, appropriate to the particular sector, is that it goes through the pool, which we call it generally a national revenue fund, right? And then, but it's not just that, it's from that pool, but then it goes, the money goes into that pool, and then it goes to the provincial revenue pool, right? And then goes into the hospital revenue pool, and then it goes into and departments and etc. I mean, I'm talking about a department within the hospital. So in various stages of this sort of pooling and disseminating, it's very difficult to, of course, say this amount of money is for X purposes, and therefore we get a Y outcome of that particular function, including even, if I may go into a little bit of PES, because it is significant change in terms of the risk adjusted, is that even though here we have these subcomponents within a subcomponent, because risk adjusted is a subcomponent, within that it's got those subcomponents, the sparsity and so forth. When the money actually goes from revenue, a national revenue fund to provincial revenue fund as provincial equitable share formula, and also allocation, it actually comes in one chunk of money, right? And from there, as my colleague Claire has spoken, is that then there is also the provincial discretion, right, by provincial governments to decide how much goes to health. So one can see that really the channels it's a very convoluted one, right, integrated one in terms of that allocation, and in various of those stages means that the decisions after decision nodes its effect and shall we say alignment tends to get diluted ultimately when it gets to the actual service at the end. And so the quantity trade-off here in relation to that is ultimately one that has to be monitored through, as we do here, and through the good oversights and holding the executive branch accountable, i.e. this portfolio committee, is, I think, taking those into account, but dive in very much into the performance indicators, and has to be more detailed than what is submitted to you by departments and entities and the executive branch. Despite us as FFC done analysis on it, and we obviously allude to some of these key factors for you to consider in terms of then deciding the budget going forward, I think please do continue with the oversight visits, and especially to do with health, hospitals, local, and in looking into the especially the informal settlements, have to look at the local environment of providing healthcare service, because have to take into account the local health demand patterns and behavior. And I mean, it depends, right? If you are close to a mining area, then of course you have to take into more considerations of things like respiratory as well as other chemical health related demands. And so it's in that sort of it becomes very differentiated, and the way to do it and to monitor, ensure performance is to conduct oversights in that at that level. Honorable Chair, if I may just ask if other team members of my research would like to say anything regarding and in response to the good questions you posed us. Thank you very much.
Thank you so much, Chen. Sabelo, any comments on your side? Claire, any comments, or are you okay?
Thank you very much. I've got nothing further to add. Thank you.
Thank you so much. Sabelo, on your presentation, any specific comments you might have to clarify?
No, Chairperson, I think I'm fine. I'm covered, because all other information will just need to be returned, because and some are things that should be answered by the department itself with respect to plans that they do have in place. Thanks.
Thank you so much for that. Commissioner Rockman, any comments on your side, or are you okay?
Thank you, Chairperson. Maybe just one or two brief comments. I think the matters raised under compensation of employees are very relevant. There is an aspect, especially around the middle to lower level employees, that we tend to lose sight of. There is, of course, an emphasis on obtaining services of medical professionals and specialists. But we tend to forget that hospitals cannot function without porters and cleaners and handymen for general maintenance tasks. So often you find in a hospital, services deteriorate to the level, or the level of vacancy rates escalate to the extent that you have nurses being responsible to perform also services that should be performed by porters. They are the ones who are pushing hospital beds to theatre. And it takes them away from their core duty, which is patient care. And it's really an issue that we need to begin to look at again. Of course, the impact of out-of-adjustment and occupation-specific dispensation, implications on compensation of employees across all provinces, you would find that that has a magnificent impact that also begins to need some attention to see, are we getting value for money at all levels, at all times. Then on the OHSC, we should remember they are not the only institution doing monitoring of health facilities in terms of compliance with norms and standards. An entity like the Public Service Commission often performs those type of monitoring visits. You also have in the offices of premiers, you have the monitoring and evaluation unit responsible for frontline service delivery monitoring. And it would be standard that your health facilities are included in their annual programs. And they conduct those oversight visits in accordance to the ideal clinic, for example, norms and standards. And I think the committee might be well advised to look at whether all of these monitoring visits, the results, properly feeds into, for example, the OHSC's database. I think there could be far greater collaboration and coordination between all of these entities that do frontline service delivery monitoring according to the set norms and standards, so that we maximize the impact. I think that will begin to compensate for whether it is a lack of budget or a lack of personnel that the OHSC might be experiencing. I think definitely the investment in upskilling their personnel and improving the efficiencies of our bureaucratic processes, that's always a welcome initiative. Then on the provincial equitable share formula, I think the introduction, even if it's at subcomponent or sub-subcomponent level of sparsity, is so important. It's a matter that rural provinces had been arguing for many years. To say, but the cost of service delivery in rural areas, even if it is for a lower number of the population, it is more expensive than in high populated urban areas. So I think sparsity as an introduction, the component of sparsity being introduced, we could begin to see over time issues being addressed. For example, the concerns raised by the honourable member on access to facilities in especially townships and rural areas. I think we will begin over time to see whether that really does have an impact. And we should hope that in other components of the provincial equitable share formula, sparsity might begin also to play a role in that. Thank you very much, Chair.
Thank you so much, Commissioner Rockman. I would like to hand over to yourself, Chairperson. I think that concludes our presentation. Thanks so much.
Yes, thank you very much. We had a very informative session now. And I want to thank Mr. Singh for the clear explanation of the flow of funds from national to provincial to hospitals. I'm not certain whether it goes directly to hospitals or via the district and some districts, etc. But that's maybe something that you can answer again. And just on my first question, maybe in writing about the keeping pace, how they are funding and kept pace with inflation, I'd love to probably get a more a better answer in terms of from an auditing position or an accounting position to just you know, a good explanation of that, just for the sake of the portfolio committee and myself in my person. Thank you very much. Then very important point that you raised about quantity or quality trade-offs. That's a very interesting statement that was made. And it's something that we should also look at as a portfolio committee, because we really have to do with people's lives and the oversight on the services which people receive at whichever level in terms of the national department, provincial departments, or its entities. So I like that concept very much. Let me then, Chairperson, give you a last opportunity. I think we've concluded on your presentation. If you, Dr. Mbaba, maybe you want to just give us a final word or two, and then we will go directly to the MGSA. I'm going to we're going to allow a comfort break after you had given us maybe a last few words for today's presentation. Thank you, Dr. Mbaba. You are muted. Can you unmute yourself?
Oh, thank you so much to yourself, Dr. Jacobs, and to the honorable members for the opportunity. We hope that we have empowered the members with the analysis we have provided. And we do undertake as well to also answer in writing some of the questions that the committee has raised, and we'll be sending those to yourself. With those words, I would like to say thank you so much again, and we hope we engage with you again.
Thank you. And you're very welcome to stay if you wish so, or to leave if you have a lot of other work to do. Honorable members, we're going to take a very short comfort break. I think we can start exactly at, let me get the time right, at 1800 hours again, 6 o'clock. Thank you. Short break. Thank you. Honorable members, just a correction. I am in a different time zone, so now my mathematics is not working out that well. So apology, I always thought of the mathematics often. We'll be starting again at 1200 hours. Thank you. We are back, honorable members. It is now 12 o'clock. Again, my apology, and honorable clerk, thanks for the reminder. Yes, you were going to come off that lightly until that late, so we're going to proceed. We have the AGSA. We have two members of the AGSA available on our platform, and we are going to have that presentation. Just as a reminder, honorable members, that just as a reminder that we are in the meeting that started earlier. We will continue with this meeting. And we have Ms. Tabelo Musisiliani and Ms. Bule Tipe on the platform to bring out the presentation from the AGSA. We would think that we should try to make up some time, and depending on how the presentation and the questions and answer session goes, I think for today we're going to try to make up some time. We normally allocate 2 hours, sometimes 1.5 hours per entity or per presentation. But if you're able to, you are very welcome to do that, Ms. Tabela Musisiliani. Welcome. Please introduce yourselves and proceed with the presentation. Thank you.
Good afternoon, Honorable Chair and Honorable Members. My name is Tabelo Musisiliani. I'm the Deputy Business Unit Leader for National D. As Chair has indicated, I am not alone. I am with the Senior Manager on the National Health side, Mrs. Muletipe. I am not sure if my other team
members are on the call, but I think she's also here with her managers. I will be sharing from my side. I don't know if I have sharing rights, Honorable Chair.
Yes, let's see. If our host can be sharing rights. Do you have yet?
Yes, I do. Thank you so much.
Please proceed.
I would ask for confirmation on the side here that the committee can see my screen.
Yes, we can. Thank you.
Thank you so much. Before we start, Honorable Chair and Honorable Members, I'd want to tender an apology for my principal, Mr. Andres Sifeto. He's the one that usually leads the delegation from our side. But this morning, unfortunately, he's caught up in another meeting, so he won't be able to join. So we are hoping today we'll actually represent him well. As Chair indicated, the purpose of our session really is to provide an update on material irregularities that we presented last year when we presented the BRRR, and then we also want to present a high-level feedback on the outcome of our review of the interim annual performance plans that were submitted by the department. I'm hoping I'll save you some time, Honorable Chair, but we'll see how the presentation goes. And I think with your permission, I'll go through the presentations because there are two different topics, and at the end, we'll then take questions from the honorable members and the chair. We'll start with our mission, our vision, and I think for us it's just a reminder to the honorable chair and the members that our role really is to enable oversight, which is why we are here today, accountability and governance through auditing, and therefore supporting building public confidence. So our role this morning is really to assist in enable the oversight, providing insights and any other matters that the committee might deem necessary, so that it then assists the committee in discharging its mandate. In the presentation, Honorable Chair, the first few slides we included one of the write-up that was done by the AG, so I will not go through it, but in summary, the AG was just highlighting the accountability ecosystem. You would have recalled, Honorable Chair and members, that even in the prior year when we were presenting, we started with an accountability ecosystem, and we're indicating that it's part of our strategy 2030, where we really would like to see an improvement in public accountability and ensuring that public accountability is really everyone's responsibility. So I would not go through what she wrote. I think it's there for the members to actually read to understand where we are going as an organization. However, in slide 5, I really want to remind the honorable members in the committee of a graphic that we then presented in the prior year. And the graphic that we presented, we were saying it's an accountability ecosystem. And where we are really coming from as the office of the AGS is the fact that we do recognize that each and every member in this accountability ecosystem has a role and responsibility they play to ensure that we see any overall improvement on service delivery in our country. And the accountability ecosystem really starts also with the leadership and the decision makers. These are the officials that are responsible on a day-to-day basis to ensure that at the end of the day, there is service delivery to the citizens. And we've highlighted over the years that they have a responsibility, whether it's according to the PFMA or any other enabling legislation, to ensure that when they are discharging their everyday responsibility, they do it in line with the PFMA or any other legislation. And also they always have, at the end of the day, the service delivery or the citizen in mind. And when we look at how the PFMA also outlines the responsibility for official within, whether it's a department or public entity, there's also responsibility highlighted for the senior manager, accounting officers, and the minister. And the accounting officers are also supported by the internal audit and the audit committee. So these are the on the, I think it's the left side, the officials that are responsible within. However, we also highlight the fact that there's also other supporting bodies that are responsible, and we highlight national provincial leadership that's available. We also highlight whether it's national treasury, provincial treasury, DPME, and all other role players involved. We are also highlighting the the scoper as well as this committee. They also have a responsibility from an oversight point of view to ensure that whatever the officials on the left, I think the left, are doing, they're actually doing according to the legislation and their responsibilities. I think in the bottom, then there is then, as the AGF say, where when we audit, our role is to really be able to provide insight, besides providing insight, and also be able to influence, and also in instances where we are not seeing change, we then bring the enforcement, which is the material irregularity. So the whole point we are saying in this accountability ecosystem, the audit, it usually comes in the after later on in the process. You know that the auditors either start towards the 3rd quarter or the 4th quarter of the financial year, and then our main audit then happens afterwards. So as the office of the AGS, sometimes we then catch things when it's too late. However, what we are presenting is to saying if the rest of the accountability ecosystem partners in this process, because they have insights, or they actually have access to some of the information during the year, if they are also able to exercise their role and responsibility, certain things can then be corrected before we come in from an audit perspective. We also realize that for the accountability ecosystem to work, we need an active citizenry, whether it's the citizens themselves or the civil society organizations that we have engaged and influenced, and they have the responsibility of also giving feedback to the accounting officers on what they are seeing on the ground, and allowing and assisting the accounting officers to be able to then amend or change or react in any other areas that is required. So I think on our side is just also a reminder to say we still believe that with the accountability ecosystem, we are stronger together, and we are able really to move or to shift the country that we all love to a better position, and to ensure that there is effectively service delivery to all citizens. The next slide just highlights what we do, because our goal is really to shift a lot, if not all, of our auditees by 2030 to be in a position where we are seeing accountability, transparency, and also service delivery taking place. So these are just our strategic aspirations and our goals that we focus on while we are working towards the overall goal of 2030. We then start with the order of the day, which is the presentation of material irregularities. I did indicate that we present some of these material irregularities in the prior, and for us today is to provide an update to the Honorable Chair and the Honorable Members. I also want to highlight a few months ago, the AG did also table an MI report, which was for the rest of government, but for today's purposes, we are then presenting just for the sector. Just a reminder on the definition of material irregularity. It means any non-compliance with or contravention of legislation, fraud, theft, or breach of fiduciary duty identified during an audit that resulted or is likely to result in material financial loss, the misuse of or loss of a material public resource, or substantial harm to the public. I think one thing we want to highlight is with the MI process, because it was a phased-in approach that we actually took with the MI process, because we understood it's a new process for both us as well as our auditees. So in the initial years, we focused more on non-compliance. However, over the years, we have then gotten to a point where we scoped in the full definition of an MI. So another area that we thought we should highlight to the committee that we are really focusing on is the material harm to either the public sector institution or the general public. And when we look at this material harm, usually we can't really quantify a financial loss per se, but these are instances where we can see that there is material harm to the public. A good example, for example, in the health sector, you'd find a situation where the sector or the specific province had concluded that there is a need to build a specific health facility, because maybe they'll realize that the area that they are at, the citizens will have to travel long hours to get assistance, or maybe there is no sufficient facilities. So the process that they'll undertake is they'll then write all the different documents that they're needed, and they would have been signed off, and even a budget allocated by Treasurer to that specific project. But then what we often see on the ground is some of these projects actually take so many years to actually complete. Some of them, you find that it's 10 years later and there's no facility in the specific area. So what we would also start considering from a harm perspective is to say, what is the impact of that area not having the facility? And this is really going to come from the fact that when there was was a motivation written and a decision that we actually realized we actually need a facility in that area. There was a need in the citizen in the area. So if the sector is not fulfilling that need, is there possibly harm that is actually taking place within that area? So those are the things that we are starting to explore. So in the future, the committee might see a lot of findings around MIs around harm. I think we've already started seeing it in the water space with the water treatment works, where we realize that if there is an instance where there's affluent being pumped into water and the citizens are going to be drinking that water, there is a material harm, because then there's the overall impact is the citizens are going to be sick. So we've already started to move in that direction in the water space. But I think what I wanted to highlight to the committee is we might start seeing some of this harm principle within the health sector. So also a reminder of why we actually raise material the MIs. We really want to instill a culture of accountability within the public sector. We also want to see an improvement in the protection of resources, as well as enhance public sector performance and encourage an ethical culture, as well as strengthen public sector institutions to better serve the people of South Africa. So some of these MIs that we raise, where there's a financial loss, we would want to see a recovery of the loss that has been incurred where possible. We also want to see in instances where they can also stop the loss. You know, sometimes the contract might be ongoing, but we want to see accounting officer also be able to say, how can they stop the loss from continuing to happen? In some instances, we also want to see the change in the control environment. So when we look at the MI report that we tabled, I think there's a number of different examples that the AG was indicating on instances where we prevented further loss, or we recovered money, and instances where we are still to recover money. The one thing I also want to maybe remind the committee, I think we do get a lot of questions to say, but the process is taking long. I think from our side, we do recognize that the process is slightly different from the normal audit reporting process, where we know at the end of July, 31 July, we are going to table the audit report. So the MI process goes beyond the audit report timelines. And this is where sometimes we are able to send an audit report while there's material report process going on the background. And I think the biggest thing is what we've learned from our side is this is also a legal process. And usually when it's a legal process, there's some delays that sometimes takes place. So what we've done so far, when you look at the material irregularities, we have referred some of the material irregularities to public bodies that maybe have the responsibility to investigate that we don't have as the Office of the AGSA, whether it's the SIU or the Hawks or the public protector. We also include recommendations in the audit report. And then if there's no implementation of those recommendations, we then also issue binding remedial actions. Right now, my understanding, Honorable Chair members, is that we haven't really issued a certificate of debt. My understanding is I think there's something that is in process, but however, we are not there yet. So the following slides just indicate the different actions that or steps that are taken from an MI perspective. I won't cover it, this is a reminder. This slide just gives us a landscape or a snapshot of the material irregularities within the health sector. I think this is similar to the slide that we presented in the previous year. If I recall, only one province was able to actually address the material irregularities. The rest of the provinces, the MIs are still in progress, and I'll just maybe highlight one or two in the next slides. By highlighting the one or two, I'll sort of try to highlight the process we take and some of the limitations we have experienced as the Office of the HSA. So the first one I'd want to highlight is the first one around Eastern Cape. And in this instance, I think that the contractor was not paid within 30 days and the contractor left site, and therefore the contractor charged the department for standing time. I think also what we saw in the material irregularities we have in the sector currently, a lot of them refers to infrastructure. I think there's a little bit of work that really needs to be done in infrastructure. I think that's the message, and that's the message we are really giving to the HODs and MECs on the ground. So in this specific instance, Eastern Cape did not settle the invoices on time, and then there was also charges by the supplier. So then they incurred then fruitless and wasteful expenditure or interest and penalties that they had to pay, and the team raised an MI. So what we usually want to see is what is the department doing about these delays in payments, while we are also assuming the fact that we do know Eastern Cape has challenges. So we do afford the accounting officer a chance to respond to us to say, we are acknowledging that there's a loss in this instance, and this is the actions that we are taking. And in this instance, we had followed up with the accounting officer, and at this point, the team was not necessarily satisfied with what the accounting officer is doing, and therefore we have then referred that MI to our MIC, it's a material irregular committee that then provides guidance whether are we going to then issue specific recommendations in the audit reports. Another one that I want to then also highlight that also forms part of the challenges that we might have is I did indicate that sometimes we refer some of these findings to other public bodies. Is the one on GP, I think the fourth one on the screen, where the matter was then referred to the NPA for further possible criminal charges. Unfortunately, we do note the fact that the other public bodies also have their different processes they follow. So what we've seen over the few years is that when we refer, some of these MIs take a while because the other public bodies have their own processes. However, we do stay in contact with the different public bodies, and we really do encourage that they close some of this MI. I think from our side, we don't let go of that MI, but we constantly then follow up to ensure that the MI is closed. Another one that I'd want to highlight, honorable members, is the one on Limpopo. It's on slide 13, the second one. And this is one of the MIs that we have effectively closed. So there's the situation that happened with this one. They were renting some radiology equipment. However, they were not fully utilizing some of this equipment. So after the material irregularity was raised, the department was able to engage with the service provider to get some sort of discount on the machines that they were not actually utilizing. So what we saw is, I think they were given 6 months where they were not charging them for the license of those radiology equipment. So from our side, this is another good example of where when we then raised an MI, there was action on the ground, and the accounting officer has taken action, and they've saved the department money because they were paying on a monthly basis, where else they were not utilizing the radiology equipment. I'm not going to go through the rest of the examples, but I think the theme we are picking up, we also picking up that sometimes when you do raise this material irregularities and the accounting officer is trying to challenge them, sometimes there are court processes that then kick in, and then it takes longer for these MIs to be closed. For the purpose of today, I just wanted to highlight the 3 instances. I will then move to the proactive review of the annual performance report. So from our side, the purpose of a proactive review of the APP really is sort of to give the department a heads up, or the department's heads up on the APP that is going to be approved for the following year. So this is part of our early warning system that we do as the Office of the HSA. And the purpose we really follow is to understand the preparation and the revision process of the annual performance plan. We also assess the completeness of the relevant indicators that they're including in the APP. And we also then determine whether the prior year's misstatement that we have raised, they're actually correcting them going forward. And then we then lastly also look at the measurability, relevance and quality of the indicators. And the process we do this is to ensure that by the time they submit it to the committee or to the minister for approval and eventually table it, it is actually, it has dealt with the issues that we've picked up in the past. What we also want to note is the fact that what we note in those APP reviews does not form part of the overall audit conclusion, because for us, it's a proactive process to give them a heads up on what might follow if they then table it without changes. So the status of the proactive reviews in the sector is as displayed. Unfortunately, at the time of us preparing the slides, Mpumalanga had not submitted the APP for review, and therefore the Mpumalanga team was not able to assist them in any of the early red flags that they might have identified. With the NDOH, we had noted some findings on the measurability. I'll just highlight some of the findings in the next slides, and on completeness. And then I think we really have seen a change or improvement within the sector, because there are a few provinces where we didn't really pick up any findings on our proactive review, and we commend them for that. However, there are a few provinces that really needs to continue working on the preparation. And when we really unpack some of the root causes around this, some of it is just the fact that there is not really proper review that is taking place in these documents. And some errors, when you look at it, actually, if there was a proper review, they actually could have been picked up and corrected before they are submitted to us. I think one thing I also wanted to highlight is that in some instances, after we have audited and raised these findings, we do not receive the final version that gets eventually signed off. In some provinces, they do send us, but sometimes it doesn't get to us. So one thing that we did say we need to try to implement is to ensure the fact that before that APP is tabled, we have confirmed that whatever we had raised have been addressed to prevent us raising the findings in the coming year. So just a summary of the findings or observations from the APP review that we have performed. I think the first one is around the completeness of indicators. So when we perform an APP review, we don't look at all programs within the APP. So we go through a process where we look at what's sitting in the MTSF. We look at where government is going or the sector is going or is headed to. We also look at what's really happening right now. And then we then select those programs for APP review. And I think with the sector, one of the programs we've been looking at over the years is Program 2, because we do understand is one of the critical programs within the health sector. And there's a lot of MTSF indicators that have been included in that program. So the observation we had when we're looking at Program 2 from the provinces as well, I think it's 2 and 4, if I'm not mistaken, as well as Program 2 and 3 in the NGOH, we did note that there are some MTSF indicators that are not included in the APP. And our position is to say, if government is saying this is what we want to track at an overall level, ideally those indicators needs to be included on the APP to ensure that the sector is tracking the overall performance or desired performance at the end of the year. An example that we had in the Northwest, for example, we noted that the indicator number of people screened for high blood pressure was not included in the APP. So the question we then raised with them is, how are you going to track this indicator? Because it then effectively feed in overall on the MTSF. I think at the NGOH, there was an indicator around community health workers integrated into the health system that was also not included in the APP that we reviewed. And we raised the same findings to them to say they have not been, the required target has not been achieved in the MTSF level, and there's a need for them to keep it, so they continue tracking it. On the measurability side, we had findings around targets not being specific. I think an example I'm going to use here, it's in the Eastern Cape, where they had an indicator target that says patient safety incident case closure rate. And when we then look at the method of calculation, they had not defined the numerator and the denominator. And I think from our side, it's one of the things where we feel like it's some of the things, if there was a proper review, it should have been cleared, because this indicator was reported even in the prior. So somehow in the finalization of the APP, that information was then excluded. So from our side, we then raised a finding around targets not being specific or indicator or targets not being verifiable, because there is no method of calculation that has been included in the APP. Another example on target maybe not being measurable is you find that they have an indicator that says HIV test positive around 18 months rate. But when you look at the method of calculation, it's talking about HIV tests. It doesn't cover the positive part. So that's why I was saying some of these things, if somebody had reviewed, they would have noted that we missed something or reviewed what they're trying to then achieve. And then I think overall, the impact that we are raising in some of these findings or observations is the fact that if the key indicators and targets are not aligned to the MTSF, there is no proper tracking. And at the end of the day, or at the end of the financial year, when the sector has to report on the MTSF indicators, they will have incomplete data because a province will not have tracked that indicator. And also when what we're raising around the issues around method of calculation, we are saying there's going to be difficulty in the collection and correlation of performance results, resulting really in accurate performance reported. And I think this we've raised over the years with the challenges we have with AOP or within the sector, where for a number of provinces, we've been raising limitations because we are unable to audit what has been reported. So our message to them is there really needs to be an improvement in the review process, but also they must ensure that the processes that they are implementing around collection and collation of performance information, it is reviewed and then it is appropriate. One of the things that we are doing in the current year, honorable members, to assist the sector in getting some of these things right. So we have what we call, it's a meeting we call 10 by 10. It is called 10 by 10 because it then consists of 10 representatives, 9 from the province and the national department, as well as representatives from AGSA side, where it's scheduled for Friday, where we are going to be in one room and we are going to really try to assist the sector to ensure that at the end of the day, when they submit their financial statements 31 May, as well as annual performance reports, a lot of the checks and balances actually have been done. So in the session, we assist them in highlighting the root causes from the prior year and things that they can do now. We do understand that it's post year end, but they actually have these 2 months to prepare their financial statements as well as the annual performance reports. So we are hoping in the session that we'll provide insights to them to assist them during this preparation stage, that the documents that they eventually submit the 1 May are a fair reflection of actually what happened on the ground. So we're really looking forward to that session from our side, and we are hoping that it's really going to assist them in hopefully when we come back towards the end of the year, we have a better audit outcome from our side if they do implement our recommendations. That's it from my side, Honorable Chair.
Thank you very much, Tabelo. Is that the only presentation?
Yes, we were only covering the interim review of APP as well as the status on the MS. Thank you.
Thank you very much. Can you just repeat it?
Honorable Chair, can you hear me?
Yes, I hear you. Can you just repeat what you had said?
I said that's it from our side. We were only presenting the update on the material irregularities as well as the outcome from our interim review of APP audit.
Thank you. I just needed to be very certain of that. Honorable members, that is the presentation from the Auditor General of South Africa. I am looking at the platform for any hands. I'm going to take the hands in the order that I see them. Honorable Wilson. Honorable Wilson, Honorable Clark, Honorable Churwa. I'm going to repeat. Honorable Wilson, Clark, Churwa. In that order for now, honorable members.
Thank you, Chairperson, and thank you to Mrs. Musisinyani for the presentation. I must admit, I find it a little bit thin on the ground. I would have liked to have seen more depth, I must be honest, but I do understand that what you're presenting is only on the material irregularities. You made a comment that the whole point of your department is to principally check on the overall delivery of services to citizens, and health being one of the most important sectors in the public services is obviously goes without saying. And my concern always is, and it's obviously not in this report, and I hope we will get a report shortly, is that generally what we see and what we monitor is if there's an improvement or a regression on leadership and management, improvement on the mitigation or regression on the mitigation of risks, financial controls, on services, etc. Now that obviously is not in this report, so we can't comment on that, but I do hope that it's coming in the report shortly, because what we are seeing is, in our eyes, particularly on the oversights that we do, is that we're seeing massive regressions on many of the services, and certainly in terms of management. So if we go to the material irregularities, well, I'm glad to see that Western Cape had none, but I am concerned about the fact that Mpumalanga did not submit, and what the reasons are for those, please. We cannot be sitting with a situation where provinces are not submitting. And you know, this information is pretty critical to us as far as our jobs on oversight and holding people accountable. And if they're not submitting reports, well, then the reason must be justified, but no justification has been given. Now, I've noted your material irregularities, and obviously some provinces are a lot worse than others. It is clear that the financial controls, potential corruption, bending of procurement rules is still continuing. And this is a concern for me, because in all the reports for many years and I've been sitting on this portfolio for almost 7, year on year, we're dealing with exactly the same issues. And it is apparent that these issues are not being corrected. It is still continuing, and we need to know why it is still continuing. Now, I know, thank heavens, that the regulations have changed and that the AG now has the powers that they did not have before to hold people to account and to take actions that are necessary. But the fact that this is still continuing shows that there is still a hiccup in the system, and we need to know why and how this is happening. The other thing, and I'm not sure where it comes in here, is that during the period over COVID, and I know that was a couple of years ago, the SIU were investigating massive, I mean, we're talking millions and millions and millions of rands worth of corruption and fraud in procurement of services and goods to manage COVID. I take it these are not in this this presentation. Certainly the indications are not that it's not, because otherwise I think we would have seen a lot more material irregularities showing here from all the provinces, because I think most of them, with the exception of the Western Cape, were involved in that. Are you satisfied that this has now been dealt with? Have actions been taken? We know that some people have been dismissed, but is the situation being dealt with as a whole, and any idea where we stand on that? And you've mentioned it time and time again in your presentation that we need to have an improvement in review processes, that people are not properly reviewing data, they're not properly reviewing reports, they're not properly reviewing information. And this is always, when we start walking on thin ice, because when that is not happening, that is where trouble slips through the cracks, and things start that shouldn't have even begun. So my concern is that it's got to be improved, it's got to be improved, it's got to be improved. We hear this year on year, and yet it does not seem to be improving. And I'm glad to hear that you're going to have this 10 on 10. But we're now at the point where if we do not start seeing improvements very, very quickly, the health sector is going to collapse altogether. It is already teetering. Services to the public, and that is what you are there to oversee as well, as long as the rest of us are just not there. They are diminishing, infrastructures collapse, services are non-existent, medicines are non-existent, staffing is non-existent. So, it's a statement from me. So, our prayer is that that you will now help manage, and I'm not saying it's your job entirely, I understand that it's not, that the department needs to be involved, but these improvements in the review processes need to happen very, very quickly. And if they don't, what is it that we would do, and what would you recommend? Thank you very much.
Thank you, Honourable Clerk.
Thank you, Chairperson. I think, to see that there is a sort of a lead by the AG to improve systems, and that's very much welcomed. I would just like to know, how successful has the early warning systems and protective reviews been? and how many cases from those reviews and early warning systems that you've put in place has actually been prosecuted going forward? And I see that in many instances you raise the 30-day payment issue, which is really a massive issue in terms of the departments. And obviously mass accruals plays a critical role in terms of the provincial budgets as well, when those accruals have to be deducted off the provincial budgets. And are you able to have made sure that with all these systems you're putting in place that issue is addressed? Then in terms of the Eastern Cape, what was the findings of the resubmitted responses? In terms of the Free State, what is the compliance status of the accounting officers? In terms of Gauteng, has meetings also been arranged with the SIU complainants and were made with the CC, and to determine whether these complaints were in fact made? And regarding the key indicators and targets that could not be properly tracked, what were the targets, and has the AG engaged with the department on how to change oversight and tracking in order to measure target achievement? Thank you very much.
Thank you, Honorable Chirwa.
Thank you very much, Chairperson. Thank you so much to the AG for their presentation. These are my questions. I want to find out on, you speak about material irregularities from 2019 to 2021. I just wanted to find out, are those the latest analysis or the latest information you have on the cases of material irregularities? Are there no updates from cases from 2022? And I know that usually you give us this information at the end of the year. But I'm asking if there is by any chance. And I want to know which of these would you rate, like in terms of severity? How would you rate them in terms of severity? Which one would you place at the top, and second and third and fourth and fifth? I'm interested in the AG appraising us with that information. And on material irregularities again, I remember, I don't know if it was 2020 or 2019, the AG was actually the true whistleblower on the Digital Vibes case, because that is when we took it up as a committee and eventually, built it up to what it was able to be after that. But on the stated material irregularities that you have there, particularly on the ones concerning, service providers and contractors, who are these people? Who are these contractors that you're referring to, especially with the ones with like big financial implications or with big amounts? I think I would like to know who these contractors that are implicated in these investigations, in these SIU bringing back of the funds and stuff like that. I think it's necessary information that the AG should have added in the presentation, as you have done in the past. And the AG is a very important institution, and we would be making a mistake if we were to imagine that it is an institution that is infantilized or that doesn't have powers as such, because the AG does. I want to know what the AG has done in defense of their own recommendations being implemented, seeing and noting the regression, noting, the insistence to not participate from different provinces and stuff like that. Have there been any court processes or legal initiatives that the AG has initiated in the interest of implementing the recommendations of the AG, and also defending, the AG as a Chapter 9 institution as well? These are the same questions I would ask ordinarily to the CGE. That after you tell us about the fact that children are being impregnated and, you know, that should be rape cases, what have you done as a Chapter 9 institution to follow that up, to investigate, to find accountability and all of those things? Now, I understand that this is a different stakeholder relationship, but I'm asking in the capacity of the AG and the resources you have at your disposal. I mean, you can also cite that as a challenge. For example, if resources are the issue, why you have not pursued certain things, and how far you were able to do or able to go. That would be grateful for me to know. And lastly, I want to find out from the AG what the requests would be in terms of how the committee could intervene. I'm also interested in that. Thank you very much.
Thank you, Honorable Gela, followed by Honorable Sheikh Imam, and welcome, Honorable Sheikh Imam.
Thank you very much, Chair. Just moonlighting, but thank you, I'm here.
Thank you very much, Chair. Chair, let me also welcome the presentation from AG's office. Chair, I've got only 2 questions that I want to ask. The first one, Chair, how does the AG's office advise on strengthening of internal processes within departments to avoid processes being delayed and mischarging of employees of employment? My second question, Chair, what are the main challenges that contribute to delays in finalizing cases, and what could be the approach of the PC during its oversight processes? Thank you, Chair.
Thank you, Honorable Sheikh Imam.
Yeah, thank you, Chairperson. I thought I'll let the AG know. Nothing to worry about. I might be moonlighting, but not at an extra cost. So
thanks, Honorable Sheikh Imam. We appreciate that cost saving.
Thank you very much. Yeah. My first question, I think, to the AG is, now, we did at some stage amend your powers. Is it helping? Is that enough, or do you believe it needs to be strengthened? What more can be done, given the fact that despite the amendments to the powers of the Auditor General, we continue to have material or irregular findings against various departments in the health sector and different provinces. But more importantly, I think that they go on year in and year out. I think enough is being done. Powers of the Auditor General must be strengthened. You know, Chairperson, we went to the South Korea recently, and we found that the Office of the Auditor General has a lot of power in South Korea, and for that reason, they are loggerheads with politicians and political parties. But maybe that is one of the things that we need to do here in order to strengthen the powers of the Auditor General, because as politicians, we tend to defend some of the people, you know, wherever we govern. But that's the first thing. Now, what do you find is the weaknesses in the entire supply chain processes? If you remember, the supply chain CEO at one stage highlighted that you lose in excess of 40% on goods and services in this country, which is running into hundreds of billions of rand. What do you believe are the weaknesses? And more importantly, do you think if there's a more transparent process, like, you know, in ensuring that people on the ground are able to get information of who's getting these tenders and things, What is the value? What is the itemized billing? Who are these directors of these companies? Are they the ones that are getting it all the time so that they can ask questions? Now, I do know that there's a provision on the National Treasury on the website, whether it's provincial governments, local government, whoever it is supposed, they're not doing it and nothing is being done about it. And remember that people on the ground don't go into these websites to be able to get that information. Do you think that might help to some extent? Now, let's look at the issue of the 30-day payment very quickly. You know, the Public Service Commission did some investigation, Chairperson, and they even found that people were not getting paid because we were holding them to ransom. The service providers, we are expecting them to give us a bribe, and that's what the Public Service Commission picked up. And then only will they pay them. Otherwise, they were all withholding the payment. Then the question is, do you really believe we're getting value for money? With the amount of money that is being spent for the different services, do you think we are getting value for money or not? Maybe you can perhaps tell us on that. And I think lastly, now, there's many of these people are repeat offenders. Every year we find the same reports coming in, same people failing us. Do you think maybe we need to have an offenders list so that we could have a different approach as to how we could actually deal with them? And sorry, lastly, Chairman, on the issue, are you picking up anything, any collusion by any chance when it comes to medical legal claims, because they on the run? It appears that the medical staff, the private sector and legal fraternity. I'll stop there for now, Chairperson. Thank you.
Thank you, honorable members. Very insightful questions by all of you. And thank you very much again to the AG for the presentation. Now, I had noted that you had chosen this particular presentation, that's on material irregularities. And one would assume that you would have had good reason to raise this in the manner that you had. And I think the bottom line is, does any of this mean that there is loss of services to the public? And in this case, the healthcare services. So I think that's probably the basis of your concern. And I would also assume requesting the portfolio committee to look more intently on this matter of material irregularities. If you can maybe just give me a short answer on that. And then you would have noted that many of the members raised concerns on whether you actually do have a bite, and if you do have, what your processes would be. How can you expedite your own processes in terms of assisting South Africa to manage these challenges which you raise? It goes hand in hand with the question of Honorable Wilson, just because I might forget to raise that question. She's asking when we will have the full financial findings of the AG presented to the committee for your noting. And then finally, from myself, I note that most of the challenges raised are actually administrative. For example, provinces not aligning themselves with some of the standards of the AG. Do you have any suggestions for us and for departments on strategies which can be considered to actually enhance reporting? So I will hand back to you, Tabelo. Thank you very much. Honorable members, also for us moving speedily. Don't leave when we are done. When we are done with the AG, we will get the CCOD immediately, and we will make up some time since it's a very long day for ourselves, and we'll have lunch after that. Thank you. Tabelo, back to you.
Thank you, Honorable Chair and Honorable members, for the questions. I think there were some honorable members as they were speaking. I think we had connectivity challenges, so I might have to request some of those honorable members to repeat their question to ensure that we covered them all. I will take some of the questions, Honorable Chair, and then Ms. Muletipe would then take some of the questions. So from our side, I think the first questions from Honorable Wilson was around the report that we presented. The audits are currently ongoing. The team has actually done some work around the interim audits, as that's also included the interim review of the APPs, hence the findings or the observations we're tabling today. But the rest of the audit is still ongoing. I think the final audit then comes through after we have then received the financial statements as well as the annual performance reports, and then that will then be included overall when we do present. I think it's around September, October. So currently we were presenting the status update as of now. So the rest of the assessment that the honorable member was looking for will then be provided at the end of the year when the audit is completed. There was a question also around the reasons Mpumalanga did not submit. From our understanding is that at the time the audit team requested the version to be audited, the Premier was still looking at the APP, and therefore the team did not receive it for review, and that's why we are indicating as outstanding. There was also a question around the SIU investigation. So we did attend, we do attend some meetings with the SIU. There was the last meeting also attend where Scope had invited SIU. In their reports, they had included the status of their investigations around the findings that were highlighted during the COVID time. And I think they really have a very good report. Maybe the Honorable Chair can maybe also engage the SIU. They had reports, and in the report, they also have success stories of where they have collected money. I think on our side, we had, because some of those findings, we actually referred them to the SIU. The SIU is currently running the process. I think the ones that we were still tracking are the ones that we currently still have under the MI report today, but a lot of them we had referred to the SIU to investigate, and they do have update reports on how far they are with the findings we had raised during COVID. I think there was also a question around service delivery. So the first part of what we do from an audit perspective, we audit from a financial point of view, the annual financial statements as well as the annual performance reports. So what we also do, and we've done over the years, I think we also have tabled it in some of the portfolio committees, is we do look at some of the focus areas which talks to service delivery. And I think over the years, we've either presented the work we've done on infrastructure, and we've also have done the work on whether it's medical legal claims or in equipment. This is us really trying to bridge the gap between the audit outcomes that we table with the service delivery that we see on the ground. I think in the health sector, we've done that. Even the current year, there's focus areas that we are currently looking at. And I think when we do present, we'll then highlight the surface focus areas that we did. And I think from our side really is to try to also look at the service delivery matters on the ground. But I think one thing that we did realize, especially because we work with our performance audit, some of those service delivery audits take longer than the normal legislation audit that we do. I think this links to the question around value for money. So in our normal current process, we don't really look at that. In instances where we look at value for money, it's when we then decide that we are going to do a specific performance audit report, and that's where we then also look at the value for money aspect. In our audits, you will see a little bit of that, but not in a larger scale. But when we then look at the performance audit standalone reports, that's when you'll see a lot of feedback around the value for money, around the spending within government. I think I'll follow up with our performance audit team. I don't know if in the current year they're actually looking at one audit that will be able to feed back to the committee around value for money. There was also a question on the early warning systems. From what we've done, we really have seen an improvement. I think One of the other early warning system that we do is what we call a status of records review. And what we do is we look at the interim financial statements that they give to us, and then we already raise findings. So some of the audit outcomes we eventually present at the end of the year, there really has been a change because of some of the early warning systems that processes that we do. It's not at the process where we'd like it to be, but we really have seen some improvements in some of the audit outcomes that we have done, where we see an improvement. I think, for example, if we take the proactive review of the APP, in instances where there were findings raised and they were able to clear them, when we then get to audit formally, then those areas we usually don't have findings because the early warning system has actually assisted the management. We also engage a lot with the internal audit teams to highlight some of the things, so that before we get the financial statements, they then look at those specific areas we are concerned about, and to some degree we are seeing an improvement. It is not where we'd like it to be as indicated, but we are slowly seeing some improvement from the early warning system. I think there was a number of questions that Honorable Clark asked, and they were actually, it was very quick. I hope some of my members have caught them, but I think there was also questions around in instances where we said the accounting officer has resubmitted information for material irregularity. So what we do is when the accounting officer submits the response to the MI, we assess the response to ensure that the accounting officer has actually dealt with the underlying issues and has improved the control environment. In instances where we are not satisfied with the response from the accounting officer, this is where we then move to the next stage of issuing a specific recommendation. Because the initial recommendation we would issue would be around they need to investigate and try to discipline where there's disciplinary required. But if when they respond and they realize that they are not addressing it, we then sometimes will issue a specific recommendation to say, you need to do this by this date. So with that, for example, the Eastern Cape one, that's at the point where it's at. Those recommendations are issued by our Material Irregularity Committee, and that's why those assessments are sitting with that committee to be able to issue a specific recommendations to the accounting officer. I think some of the questions I'll allow my colleagues to assist in that. There was also a question around the latest material irregularities. Honorable Chirwa is correct, because sometimes it takes years for us to close a material irregularity, because we'd want to be comfortable that the internal control environment has been improved, disciplinaries has taken place, and money has been recovered. We do leave some of these material irregularities open for long. However, there are some material irregularities that have been identified. It's just that at the time of reporting, because we are still to notify the accounting officers, we do not include them. The Honorable Chair and the members will then see them when we present later in the year some of the material irregularities that we are raising for the financial years that we are currently auditing. There was also a question around a rating of severity. Currently, we have not rated the severity of the material irregularities. However, if we go back to where we are moving as an office, we do know that we've raised a lot of MIs around the 30 days payment and also interest and penalties. But I think for us, we are also moving towards harm MIs, because we do realize the fact that those have a bigger impact on either the health of the citizens or the safety of the citizens on the ground. I think as we start raising the harm MIs, even though we don't have a rating systems, those ones will most probably have also a bigger impact from an MI perspective. But currently, we don't have a rating system. There was also a question around the suppliers. Unfortunately, we don't have the names of the suppliers. Maybe what we could do, we can then engage with the respective provinces and see if we can provide something to the committees. But currently, as we stand, we don't have the name of the suppliers. I think this also links to one of the questions around the list of offenders. According to our understanding, National Treasury Treasury does have a list of prohibited suppliers. These are instances where the supplier did not perform or did not comply. The department have a platform to actually report those suppliers, and then Treasury then publishes them as prohibited suppliers. And that's a tool where, as the department is sourcing service providers, they know they must actually check it and ensure that they don't then do business with those suppliers. There was a question on what we have done in terms of recommendations. I think I'll go back to the MI process that we have. So the first step that we do, we raise a material irregularity, and then we allow management to then do the process of investigating and identify and confirming the material irregularity. So that also has 20 days according to the material irregularity process. The accounting officer has 20 days to write back to us to say, this is what we have investigated, and this is the outcome, and this is what we are doing. So in instances where, which is referring back to the question around the submission of information, the Eastern Cape example, in instances where we see the accounting officers are actually not implementing or doing anything about the MI, this is when it then moves to the recommendation stage, where we then issue a specific recommendation to instruct the accounting officer to either investigate, and we then give them a timeline. So those are the processes that we then follow, and depending on the outcome, we can then go to the remedial action. So that's what we are following currently to ensure that the accounting officers are actually implementing our recommendations in the material irregularity process. We do know that sometimes it does take time because from a legal process that we need to allow them sufficient time to implement what we have issued, and we understand that sometimes where there is also disciplinary proceedings, those processes takes longer than what we would have loved as the office of the AGSA, because it then also follows another legal process from their side to discipline the specific individuals. So we do understand that some of these processes are taking longer than we would love to, but I think usually when the legal process kicks in, we sort of have some sort of limitations from that point of view. And I think one of the questions around how can the committee intervene, I think I'm going to give it an overall perspective. So we usually on the yearly basis say the committee needs to then call to account the accounting officers. I think one thing that we really recommend is the tracking of these commitments that the accounting officers really do. So what we realize is if they can come this year and say this is what they are going to do, they really need to be a tight tracking process to ensure that what they committed in their previous meeting, they are actually continuing. Another example would be if, for example, there is an infrastructure project that they are actually involved in, is to be able to have a tracking mechanism to say, in this quarter, an accounting officer presented that this is what they want to do and where they are, and consistently track them to be able to hold them accountable, because we do realize that because there's a lot of things happening, certain things might fall through the cracks. And I think maybe if the committee has a way of checking and reminding this accounting officer that you told us this last time and we are not seeing progress, what are you doing about it? I think there was also a question around the advice on strengthening the internal processes. So the process that we follow in an audit perspective is when we are auditing and we identify a weakness in internal control, we include a recommendation to the accounting officer to improve the internal controls. The improvement could be the maybe hiring of skilled staff, or to really send some of the staff to training if we see a gap from a skills point of view. So what we then do with every finding, when you raise the recommendations, the accounting officer includes an action plan to say, this is what they are going to do at a given point in time. What we then do from our side before we start the audit, we then go back to the action plans that the accounting officer had committed to do to really follow up to ensure that they are really implementing that action plan. So that's usually how we then assist them in strengthening the internal control processes. And we also then do provide feedback to say, your action plan that you are actually suggesting, we don't think it's actually going to address the root cause of the problem. like I said, we also have sessions as well with the internal audit to sort of empower them to assist the accounting officer in ensuring that the whole internal control processes is actually improved to at least at the end of the day, improve the audit outcomes that we see. If I have missed any of the questions, my colleagues will help me. Some of the questions, I was actually consolidating them in my responses. Mule, please assist if I have missed a question, or the honorable members can remind me if I have missed a question.
Thank you so much, Tabelo. Good afternoon to the Honorable Chair and the Honorable members. I think there was a couple of questions that were asked again in terms of the MI process as to whether we are satisfied with the MI process. And the other question that was asked is, are the powers relating to the PAA assisting us in this regard? And our view is that it is showing some improvement in terms of the processes. So there's instances where there were losses that were recovered from the eyesight through this process that we have followed through the MI processes. So it's a testament that the amendments to the PAA is assisting in this regard. And then there was also a question that was raised relating to what more transparent can the SCM processes be? So I would like to answer it in twofold, to say in some instances, you would find that there would be a contractor who's submitting invoices for work that has not been done. This is a case in point for the MI that was raised in the Free State. So this is a case where the supplier submitted invoices for work not done, and yet the department, the official from the department certified these invoices, which is what is incorrect. The official was supposed to have held or maybe caught up the issue before it then goes through to the payment being paid to this specific supplier. So the internal control, it becomes quite key in this whole process. Another thing is what Tabelo has also mentioned, to say the review of the documents, the review of the payments before payment is being done. Those are quite key in this whole process. So I just wanted to touch on those two. I think you have covered the bulk of the questions that were asked from the committees. And then there was another question relating to the medical legal claims. And on this one, we tried to do an analysis of the sector claims that came through, but we're still going to continue with that in this year. Last year, from the analysis that we've done, we have reported to the we reported to this committee at the BRRR session. However, what we wanted to do was to get some of the information relating to the lawyers, the law firms that are involved in these cases, so that we are able to see if we're able to get a message or to do a proper analysis on the lawyers that are handling all these cases relating to the medical legal claims in this regard. However, we had a bit of a limitation relating to the information that is captured by the provinces. You would find that some information that we need, a requirement that we need, for example, they need to be capturing the law firm. In some instances, the information is not captured in a more consistent manner for us to be able to do a proper analysis. There are those data limitations that we get when we try to do the analysis, but we will be doing the same process again. We have sent out the request for information to the provinces for them to come to us and to be able to give us the information so that we can do the analysis. I think I'll just pause there for now with your permission, Chair. Thank you. Oh, sorry, apologies, Chair. Just one more thing. On the question that was asked relating to what can the committee do to assist us relating to the MI processes. So I think it's dependent on where we are in terms of the MI process. So for example, where we have identified the MI and the accounting officer is dealing with that MI, the oversight committee can assist in terms of monitoring the progress and calling the accounting office or the DG to account for the actions taken and the outcomes. And in instances where the MIs have been referred to the public bodies, the oversight committee can assist us relating to holding those oversight committee, those investigative bodies like the SIU, for example, calling them to account, because we've seen that in some of the cases, or maybe even most of them, there's instances where the investigations take quite a long time. Although we do understand that they might not be having enough capacity, but we have seen that some of these cases, they take quite a while if we have referred them to the public bodies. Thanks, Chair. Thanks.
Thank you very much. I'll call you on your first name, Tapelo and Mule. Very much appreciated presentation, your input, your answers to questions. Better informed, so we appreciate it. Maybe 30 seconds for any one of you. I think that will be Tapelo.
Thank you so much, honorable honorable members. We really appreciate the opportunity to be able to appraise the committee on what's going on the ground. I think as indicated, if there's any additional information that we might have missed, the honorable chair is welcome to send a request, and then we'll then respond accordingly. I think that's it from my side, Chair.
Thank you very much. Honorable members, with your indulgence, we are going to continue since we have made up a bit of time. I hope you can keep your hunger pains a little bit longer. I have asked Dr. Kisna Sami, who's the commissioner of CCOD, called CCOD, but I think it has a new name called Mines and Works Compensation Fund, but he can probably answer that better than what I can. I've asked them to join us a bit earlier so that we can, and it's a short presentation from what I've seen, so we'd be able to get their presentation, ask some questions and get some answers before we adjourn for lunchtime. So I really hope you will not disappoint me and accept this gift that I'm giving you, honorable members. On Dr. Barry Kisna-Sami, can you please switch on your microphone, introduce and your camera and introduce your team and go straight over to your presentation. Thanks.
Thanks, Chairperson, and good afternoon to the honorable members of the Portfolio Committee. I'm gonna put off my ears to just save because of power load shedding and problems with the bandwidth. If you don't mind, Chair, and then I'll put my presentation on. And input, and then and because of time constraints, and we know you've had a long morning and we are between you and lunch, so what I'm going to do is just not go by individual names, but just to say that we've managed through Dr. Botas to contact most people about the change from 230 to 1. So there would be people joining probably from Minerals Council, trade unions, the ex-Mine Workers Association in Southern Africa. There are colleagues from the Eastern Cape, and I'm hoping that Deputy Minister could join. He was in the Eastern Cape, but we'll talk about that later on in terms of the outreach activity. And then, of course, officials from the National Department of Health, MBOD, CCOD. And I'm not too sure if Auditor General will still remain, but greetings to the colleagues from Auditor General. So, Chair, I'm going to put on my screen and then just share the document. And I'll switch off my video. Chair, is it showing?
Yes, thank you.
Thanks, Chair. And we're always grateful to be able to present to the Portfolio Committee, especially because of the gains made with the support of your committee, Chair, over the last number of sessions. So we are going to present the APP for the next financial year. I'm just going to go to my pointer options. So just to reiterate, in case there are new members of the committee, we provide a fund that covers occupational lung diseases in workers in mines and works. And of course, mines are known, works are refineries, smelters, etc., that process the minerals from our ground in South Africa. So a iron smelter, for example, which makes steel from iron ore, and a chrome smelter, which helps with ferrochrome, etc. So we provide medical assessments, and Dr. Machali and the team are here that does the medical assessments and certifications of claims to see that they are valid. And then we pay pensions out of statutory funds. This relates to the old act. It's mainly about, I think, 20 pensioners that are left, but Mishak Maswangani would speak to that. And then we process compensation claims. And then for the fund itself, the Mines and Works Compensation Fund, which you referred to, Chair, there is some changes, but I'll come to that in a minute in terms of the changes for the Mines and Works Compensation Fund. So the good news, it's still not ideal, is that we've paid out now 1.36 billion rand over the last 7 years. Remember, a new management came in as of 2012. I was appointed the new commissioner by the previous Minister of Health, Minister Motsoaledi. So 48% of the payments have been done since this new management has come in, compared to 2.86 billion being paid over 25 years. We finalized 51% of the claims over the last 7 years, compared to about 100,000 claims over the last 25 years. And very importantly, we presented our annual report last year, and we reached the stage of an unqualified audit with no material findings. Just to raise, it's a busy slide in terms of country and claims. And this is the line I'm referring to. You can see the bulk of the claims emanate from South Africa. This is the 1.36 billion over the last 7 years. 864 million went to South Africans. 358 million went to Lesotho. And this is the legacy of the migrant labor system, where approximately a fifth of the ex-mine workers actually are from Lesotho. We talked about that's 200,000, 300,000 are from the Eastern Cape. And then by province, you can see that the Eastern Cape makes up the bulk. Almost 50% of the payments went into the Eastern Cape, followed of course by Free State and Northwest provinces. Of course, members will still recall we still have unpaid claims of about 1 billion rand to 80,000 claimants. This the highlights. Just to recap on the organizational environment. All annual reports are up to date in terms of submissions to Parliament. And as of the 31st March, and the APP, Chair, that we submitted, the details in italics were at 31st December 2022. We've just given you the updated figures in terms of up to 31st March 2023. So in terms of business processes, we currently doing about 851 certifications per month compared to 477 in the previous financial year. 557 claims were finalized compared to 512 previously. We paid out 170 million, of which neighboring countries, about 50 million went to the neighboring countries. Organizational, no major changes other than we must congratulate Ms. Tembi Mama, who is the Deputy Commissioner now. She was acting, and then since Mr. Sam Molotsi retired, and she's now the new Deputy Commissioner and will be talking later on in the presentation. So fairly stable in terms of the personnel. We do have some vacancies that we are in the process of filling, but it takes time in terms of getting permissions. Remember, we are a cluster within the Department of Health, and we follow the transcripts of the Public Service Act in terms of the filling of the posts, etc. So we have to get permission from the DG and then go through a proper process in terms of filling of posts, but we are moving on that. In terms of the personnel spread by disability and race, this is the spread in the organization. And then just some business processes. The blue bars refers to the work in the period, 22-23. We will be looking at 21-22 to 22-23. The orange was the 21-22 period, and the blue was the 22-23 period. So some progress in terms of certification, some progress in payments. And you can see we took a low dive in terms of the COVID areas, and then with changes in the IT system, but we are picking up in terms of claims certified, thanks to the work of Dr. Machali and team and Dr. Rabada. And similarly, claims paid, an upward curve. This you were referring to, Chair, in terms of the legal status. While we will spend some time on the Occupational Diseases and Mines and Works Act reform, which sorts out the entire cluster as a Section 3A entity, but we are willing to note, because this was a major problem for the Auditor General and ourselves, that up to the 28th of March, we were known as an unlisted public entity. So the Mines and Works Fund, which is overseen by this committee, and this APP that we are providing is related to the Mines and Works Fund. So as of the 28th of March, we are now a listed public entity in terms of Section 3A, and going forward, the Auditor General will then audit the fund as a listed public entity. And we have started with the audit planning for the 22-23 financial year in any case.
Commissioner?
Yes, Chair?
It's a short moment. There were two members, I think they're probably from your team, who wanted to log in, or they were requested to change, it's noted as their phones, to change to their names. And if they don't comply, we are unfortunately going to remove them, because that means we wouldn't have powers over anything that they would do. So we would want them to name their devices properly. I'll probably give them 3 minutes, and if not, we remove them. Thanks. Please continue.
Oh, okay. I do apologize, Chair. Sorry about
that. Just say to them now while you're on the platform.
Okay, no problem, Chair. Thanks in terms of parliamentary privileges that are extended to us, and we apologize. I'm sure they will sort themselves out, and we leave it to you then to sort out the admissions.
Thank you.
In terms of the revenue side, Chair, remember this was the qualification on audit. We had disclaimers, and then we went to a qualification on revenue. So we've played a major role in terms of sorting out the revenue side. Of course, we are relying at some stage, Chair, on a offline discussion with your office about the links to the Portfolio Committee on Mineral Resource and Energy because of this issue around mine closures. So there are 859. Let me just get to it. There are 859 gazetted mines and works, but 219 active mines and works that are paying to the revenue fund of the Mines and Works Compensation Fund. Of course, many of these old mines are now closed, but we need the mine closure certificates. And this has been the rallying call from Auditor General, that how do we know that we are collecting the adequate amounts of revenue? Of course, they've given us a clean bill of health in terms of the unqualified audit in the previous financial year, but we have to continue to do this work. So we're still continuing with a special effort on collection of revenue and completeness of the Register of Mines and Works. And in fact, we've issued now our first summons in March to a listed entity for collection of revenue. So there's active work going on by the financial management team led by IP Capital, which is funded, of course, by the Minerals Council. Chair, I'm just going to hand over to Ms. Mama via you, Chair, to take us through the financials. There's a financial team that will explain the financials. Ms. Mama is leading the team. Ms. Mama, over to you through the Chair.
Thank you, Commissioner. Good afternoon, Chair, members and colleagues. My name is Tembisa Mama, and I will be presenting financial performance of the Mines and Works Compensation Fund, and I will be presenting the current results. And they are all audited up to 21-22 financial year, and obvious 2022-23 is estimates. So I will start with the income. I'll present the income versus the expenditure. Our income is from the levy. I will concentrate on 2021-22, 2022-23. We see a decrease from 128 million to 126, and this is due to a decreased levy rates, risk shifts being constant,
And we also have the interest income, which is, we see that there's an increase from 208 to 206, and this is due to an increase in the interest rates. And also we do have transfers, Chair. These are 22 pensioners that the fund is still paying, and these are from the old Act. So hence we see the decrease from 466 to 372. Chair, I will go to expenses. We see an increase from 271 to 449. 449 being the estimate, actual valuation report. We're still waiting for the actual valuation report. Once it's confirmed, then the figures might change. Next slide, Chair. Thank you. And then we'll do the balance sheet of the fund, starting with the investment. 2021-22, we see an increase from 5 billion to 5.3 billion. And this is in line with the increase in interest rates. And we also have receivables from 16 to 9. And already this is due to the effort that has been put by the team in clearing old debtors. And we worked very well with legal over this issue. Hence you see the decrease. And cash equivalents, this is really operational as we draw money and put funds as we need the funds. And also the good news is that the fund is overfunded by 1.5 billion. Also, we have provisions. We see an increase, and also once we get the actual valuation report, the figure then will be confirmed. Thank you, Commissioner.
Chair, to go on to the focus areas in this performance plan. So we're in a maintenance mode, and one of the big areas, of course, is to continue with the claims management process. So the database of works and of workers and ex-workers, and Chair, we would ask for special indulgence, if time permits, for Andre Fourie to demonstrate the active mine worker database, which will also ask ultimately portfolio committee members, if they got constituencies and constituency officers, they will get access, authorized access to use our mine workers database. So this database is now state of the art, controlled, and it's a lookup tool in terms of whether a mine worker has multiple funds due to them, social protection, etc. And it's also being linked to the mining companies and covers also ex-mine workers. We also have a very active program led by Dr. Rabada on the digitization of our health records. And we hope later on, hopefully with the annual report process, or if we are called to Parliament earlier on, we'll demonstrate that the digitization of our health records and bringing that also into the database. So it's fascinating in terms of having an electronic claims management system, an electronic web-based database, and a lookup tool, and linking up with our and the database and the lookup tool and the electronic online system is at the moment being rolled out in the Eastern Cape, where the Deputy Minister currently is leading a team together with the Premier of the Eastern Cape and the other Deputy Ministers in terms of an outreach activity in 3 districts in the Eastern Cape. The expansion of the claims management system is very important because we have the legacy problem of now R1 billion in unpaid 80,000 unpaid claims, and one of the big issue here is to get clinical records that go back in the case of the Shiamiso Trust, the class action settlement, to 1965, and to pick up a health record, because a health record is a very important tool in the event of a deceased claim, and then also linking up the claims management system to the banking system and to other social protection funds. And then linked to that is to the decentralized sites like the ones we have for the outreach activities, the 4 one-stop service centers. We are in discussion with the Global Fund for the neighboring countries and SADC, and we are in discussion with the mining companies in terms of taking the online claims management system into the mining companies. So tremendous work being done in terms of the online access and decentralized service delivery. And then lastly, it's something that's taken for granted, I guess, by your committee, that we should be submitting financial statements and annual reports on time. But as you know, the backlog that we had previously, so this was in our strategic plan, that we will submit the financial statement for 22-23 for audit by the Auditor General by the 31st May. So that's the important inputs. And then the much more granular detail. Let me start with the amendments to Dimwa. So Chair, unfortunately, we know your committee was very important and was waiting for these amendments to come through and to process the new bill. The bill was ready, but we then had to go through state law advisor for final certification prior to the cabinet process, and we only concluded that process 2 weeks ago. So the reality is that because of the other hoops in government to take the bill through the social cluster, the forum of Director Generals, the cabinet subcommittee, and then cabinet, published for comment then by cabinet for 3 months, and then consolidated and brought back to your committee, this unfortunately will take place possibly in the new administration. So we did what we could, but we basically ran out of time. And we know that Parliament has a short session this year. You're still caught up with a range of backlogs of bills. So this is not coming through to the parliamentary process until the new administration. But the amendments have been done, and it covers, as we talked previously, on the levy changes, on covering all mines and works, on dealing with service delivery, the levy covering health services, etc., and creating a new board of authority for the fund as a Section 3A public entity. The effectiveness and efficient management, this is the master database which we want to demonstrate. So I'll leave that to later, Chair. And then in terms of certifications and benefit examinations, there were some dynamics with performance. Of course, this is due to be audited. In terms of the targets, it was due to changeovers in the IT system, but also we were still coming out of service delivery problems. In order to do the outreach activities, we needed funds, and we hadn't conducted enough outreach activities to bring in more benefit medical examinations. And then with the benefit medical examinations, you then do certifications, and after the certifications, you do payments. We have retained, of course, the targets because we are working quite closely with the Shiamiso Trust, which has provided the heavy lifting for the outreach activities. And we hope that through that process, we would overlap some of the certifications and the payments. In terms of claims finalized, it's the same issue then ultimately that relates to from the certifications. And then this was within 3 months of receipt of all documents, and we had reached the target, and we still maintain the 80% process going forward in the APP. In terms of revenue payments and inspections, performance was at 81%, and we've kept the target at 80% of control mines and works paying levies. Of course, this relates largely to the larger mines and works who in the sense cover 80% of the workforce that we control, Chairperson. And then submission of the audited annual report and financial statement to the Auditor General. We had submitted the previous one, and we currently busy with the current one. And then inspections of mines, 77 is the target. Performance was 95. We only have 3 inspectors, so they've done a tremendous job. Because some of the mines are in far-flung places like Otterzell, the manganese mine, Katu in the Northern Cape. There are mines on the west coast that we have to inspect in Limpopo province. So it takes sometimes 2 to 3 days for an inspector to get out to the mine. I'm going to hand back to Ms. Mama, Chair, to continue with the financials. Ms. Mama or Kerat?
Gerald, Commissioner.
Through you, Chair, Gerard.
Good afternoon, Chairperson and honourable members. I will assist take us through the budget of the Mines and Works Compensation Fund for the NPF period. I think if we look at the total revenue from the current year of 433 million, we're looking to increase that to 542 million over this period. Mainly, as you can see on the slide, the higher interest rates, and the on the investments will gradually increase from 306 million through to 402 million. Slight drop off in the last year as we expect interest rates to just ease a little bit in the outer year 25-26. Also linked to that, the levy income steady state in the first few years and then a gradual increase in the 24-25 year. As Ms. Mama mentioned earlier as well, in terms of transfers, this is an old act and we are gradually seeing around about 10% per year decrease in the transfers from 372,000 in the current year down to 191,000 in the 25-26 year. The expenses line item, which mainly encompass the movement in the provision, we see a gradual increase from 439 million through to 543 million. And just again, to reiterate, this is of course, dependent on the actual valuation. And once we get the new evaluation, we adjust the budget accordingly. Next slide, please, Dr. Perry. With regards to the balance sheet, three main items which encompass the fund, which is the investment, the accumulated surplus, and the provision. And we see on the investment line increases. We foresee increase from the current 5.3 billion through to 6.5 billion in the outer year. And then, as Ms. Mama also mentioned, the fund is currently overvalued and we are sorry, in surplus, I'll try to rather say. So we see that surplus, we see an increase there from the current 1.5 billion through to 1.7 billion in the outer year. Currently, provisions, we are forecasting that the current 3.7 billion will increase to 4.7 billion in the outer year. Payables, cash equivalent, and receivables, we've got sort of steady state there, and we don't see big movements over the budget period. Thank you very much, Chair.
Chair, in general, the fund is in a healthy position in terms of the provisions in the balance sheet. So just to come to the concluding slides, so it continues to stabilize the number of claims, and we're working with social partners, and many of them are present in this meeting today, Chair, the Ex-Mine Workers Association, the trade unions, the mining companies and the Minerals Council, the class action lawsuits, neighboring country governments and provincial and local government and traditional leaders. So we worked very closely with these multiple interactions in terms of enhancing service delivery and input. So we'll continue to work that out, like the outreach that we have in the Eastern Cape right now. And we're continuing with the benefit medical examinations at the one-stop service centers through the use of mobile clinics, mine health facilities, etc. Enhanced tracking and tracing of unpaid claimants, enhanced revenue collection, and then of course the actuarial valuation as at 31st March. Mr. Mishak Maswangani is going to deal this provision is from voted funds. This is the monies that are covered out of the Department of Health budget that pays my salary and other activities. Just a note that the Minerals Council provides a further 60 million, which I'll talk to after Mishak has presented this budget. Mishak Maswangani, through the chair.
Thank you, Dr. Berry, and good afternoon, Honorable Chair, Honorable members and colleagues. So I'll be presenting the voted funds for CCOD's day-to-day administration, that is actual versus budget for 2022-2023. So under compensation of employees, we were allocated a budget of 34.4 million, out of which we spent 33.7 million. That resulted to spending of 98%, with the 2% underspending. So that is due to the vacant posts that existed, and we're busy filling those posts. So under goods and services, we were allocated 23.6 million, out of which we spent 16.7 million, which resulted to a 71% spending, which is 29% underspending. So mainly that underspending is as a result of the procurement process overlap, like in the previous financial year, 2022-2023, we embarked on the procurement of benefit medical examination services. So that was not finalized, and it will be finalized in the current financial year. So under transfers, that's 1.5 million. That's the funding that we received from Treasury to pay for the monthly pensions as a result of the old act. So under capital expenditure, we were allocated 3.6 million, out of which we spent 1.2 million, which resulted to 34% spending, which is 66% underspending. So if you can look there, the underspending in terms of percentage is a bit material, but in terms of the value, it's 2 million underspending. So again, that is as a result of the procurement overlap, because in the previous financial year, we embarked on the process of procuring computer equipment, biometric equipment, and furniture. So that was not finalized as at 31st March 2023, and that will be finalized in the current financial year. So overall, we were allocated 63.2 million, out of which we spent 53.2 million, which resulted to 84% spending. So next slide, please. Okay, so this one is the voted funds budget for the MTEF period, which is over 3 years, from 2023-2024 to 2025-2026. So overall, for 2023-2024, we were allocated a total budget of 68.4 million. Then for 2024-2025, it is anticipated that there will be allocated 71.4 million. 2025-2026, it is anticipated that we will be allocated a total budget of 74.9 million. Thank you.
Thanks, Mishak. So this is the process right now, and we are working through the procurement processes. Again, we are part of the Department of Health procurement processes and human resources, and we're working through that. But one of the issues is to prevent the end of the year rush and hence some of the problems that we've had with underspending, Chairperson. Let me just get on to the concluding slides. So in terms of inadequacy of voted funds, we get an additional 60 million in kind from the Minerals Council South Africa through a voluntary levy. This began approximately 3 years ago. So they've and prior to that, the Gold Working Group provided support to the MBOD CCOD, and it's modulated by a memorandum of understanding signed off by the Director General. And this year, an additional 60 million was made available. That covers the financial management staff and systems, the information technology online claims management system. It manages the seconded professional, specialized professional staff that actually support my office. And it's just been a tremendous partnership in terms of going forward. There's also been work for the outreach activities and work that we've done in efficiency gains. For example, computer-aided diagnostics for TB and silicosis, and also working through like the digitization project right now. So hopefully with the amendments to DIMWA in the new administration, that the levy will become a statutory levy to cover this as opposed to the voluntary levy. So we do appreciate the Minerals Council heavy lifting, and some of the other mining companies have also assisted to support some of the outreach activities. The register of control mines and works is very important to continue to work with this. And I mentioned earlier, Chair, that we issued the first letter through the Sheriff's Office for the recovery of funds from one of the major listed companies, and we'll be pursuing that. We now have a full debt collection model that's taking place, including going after liquidated mines. If they're still in the liquidation process, then we are also going after that. So we really appreciate the work being done by the financial management team in managing the revenue side. We discovered as we went through this path that health professionals don't know enough about occupational health. They don't know enough about occupational lung diseases. And we're having a special program. Thanks again to the Minerals Council. There'll be training of health professionals. We have a major workshop for 2 days in Sandton in May during Workers' Month to train health professionals on recognition and referral of work-related problems, including occupational lung diseases. We're hoping to conduct that training program in most of the provinces, notwithstanding the issues with the start off with the program in Johannesburg. And then nothing is possible without working with the multiple stakeholders and that help us to achieve the outputs of restoring dignity, paying dues that are due to the workers. We cannot bring back health because of the nature, or other than TB, because of the nature of these occupational lung diseases, which are incurable. But at least they can see that we've actually paid out the compensation, and working closely with the Shiamiso Trust, actually improving on the financial contribution. So we've been really responsible for this. I'm not too sure if Deputy Minister has joined. He might, if he has joined, Chair, could probably talk a bit more about that. So just to acknowledge the different people that play a role in our lives. And Chair, let me stop there and ask your indulgence if we can just ask Andre Fourie to demonstrate, get sharing rights and demonstrate the master database. He's going to use dummy tables, and with your indulgence, Chair, Andre Fourie.
Certainly, Dr. Kisnasamy, but let's try to speed through it. Thank you.
Thank you, Chair and honourable members. And I'll just quickly give you a brief presentation of the online database. So you can see this is the landing screen where we allocate upon Dr. Kitsasamy's approval, a user will get access rights and then we'll log in here. This is the actual live database, but I've just inserted a dummy record just for demonstration purposes. So I'm going to search for Dr. Kitsasamy. This is not real data. So you see these other ones are real data, but there you can see Dr. Barry Kitsasamy with the minus number there. So that's just a dummy record that I will show you how it works. So there we have found him. We can view him. Here it gives you these demographic details, his name, his address, etc., his cell phone number. I'll show you now where the front-end users can update these details. And then here it gives you a brief overview of all mining-related unclaimed benefits that due to him. So here we can see he's due a benefit medical examination, the MBOD, and we know that he visited the National Department of Health facility at Port St. John's because we share data with them. We know he's got a Capitec bank account due to data exchanges that we've done with Capitec. And we know also he's got a potential unclaimed mine workers provident fund. We have access to their data as well that we regularly update. And we've got an agreement with them to show their potential benefits on this website. You know, it's got a Ubank unclaimed fund in one of his Ubank accounts, potentially Rebecca Trust unclaimed, pension fund benefits, same for Sentinel, then also some additional CCOD unpaid first degrees, and then also he's already received the loss of earnings claim. So like I stated, this is not real data, but it's just a demonstration of the data that we do have available, and it is shown for the actual beneficiaries as well. Then, so what will happen is a front-end user will identify the person, and if he makes contact with the person, he can go in there and update. For example, if we've got his new cell phone number, you can update his cell phone number and type there that I saw this person at the Port St. John's outreach, for example. Then if you update the info, you'll see
Andre, I think we lost you, but I think it's fine, Chair. I think it
Yes.
shows.
So sorry, that's it from my side. Thank you.
Chair, back to you, and thanks for allowing this. So this shows you now a comprehensive database that has been made possible through the support of the mining companies and the technology platform. And this is online across the world in SADC, etc. We launched a satellite dish link in the outreach, for example, today in Konduli with direct links. And we are hoping that your constituency officers will also get access after authorization in terms of the process so that we can reach our people on the ground. Chair, thanks to you, and over.
Thank you very much, Dr. Sami and your team. We are very happy that we had participation with you. We see you've really done well with all of your financial statements and your auditing. Even getting an unqualified audit, so it was well worth the while to this committee to have been so kind to you, Dr. Kisna Sami. We're very proud of the work that you're doing, understanding the need that our people have in terms of money that should really be theirs and which they should receive before they pass on. And we know that some have actually, and family members, I am very certain, are also in quite a bit of a need of monies that should be accrued to their parents, grandparents, etc. And so we are proud of the work that you and the team are doing. I'm going to take a few hands, and then I'm also going to ask a couple of questions and get some input. Honorable Gela is first, followed by Honorable Wilson, followed by Honorable Clark. Honorable members in that order, and then Honorable Churwa.
Thank you very much, Chairperson. Let me first welcome the presentation from CCOD. Chairperson, I'm having a network challenge due to load shedding. But my question, Chair, the first one, what are the plans by CCOD to ensure that is able to fill the vacancies that are there? Second question, Chair, what kind of a special effort are being put in place to address the issue of collection of revenue and completeness of register of mine and works? The other one, by when will the amendment to ODMWA CCOD does not have a specialized personnel within its structure? Does the CCOD have a memorandum of understanding with the Minerals Council or South Africa? If not, why? And if yes, explain its content. Lastly, Chair, if they can also explain the measures being taken to make the office more accessible given the increasing demand for its services. But Chair, I must appreciate the good work that they are doing and also the outreach program that is led by the DM of the department, Dr. Dlomo, to make sure that the ex-mine workers are getting what is due to them. And also we'd like if we can be invited as a portfolio committee, of course, lobbying even the other members so that we also see what they are currently doing, as now they are at Eastern Cape, but we love also to be invited so that we can join them in terms of making, we also do monitoring and oversight. Thank you, Chair.
Thank you, Chairperson, and thank you to Dr. Nasami. Always a pleasure, or it has been a pleasure, getting presentations from you over the last couple of years, because I think we can all see, and I think we're all confident that you have made quite a lot of progress, and that you certainly seem to have got the situation under control. Just a couple of questions from my side. So I have concern about the 71 on 71% of budget, only 71% being spent on goods and services. But obviously even more concern about the 34% only being spent on your capital expenditure. Now, I understand that, well, the explanation was that there was a carryover or a crossover on contracts and payments. The question is, though, do these go forward as accruals, or are you obliged, because it's an underspent, to return this money to the Treasury? That's always very, very concerning, and we don't like to lose funds, particularly in health, when every cent counts at the moment. You talked about the inadequacy of voted funds and not getting your funding from some of the mines who are now facing liquidation. And I think this is a situation that is going to continue and potentially get a lot worse. The current water and electricity constraints in South Africa are having a severe impact on the mines. Many of them are not able to run optimally. They're running at major losses. And I think we're going to see more and more of a situation where mines are going to really battle financially, and therefore that is going to put you under strain. Have you got plans in place to deal with this? What are you going to do to mitigate these risks? Because I think it's a risk that is very real. And then just a quick one, Doc. So years and years and years now, we've been dealing particularly with mines, taxus, asbestosis, TB related to that, lung diseases is related to that. But can you give us some idea of what has changed in the mines in recent times? We don't want to be continuing for the rest of our days to be paying out claims. Paying out claims we must do for those people affected. But at what point do we get to the stage where mines are running at such a situation that asbestosis and lung diseases as a result of mining come to an end? I know at the stage we're finding a lot of people from the old mining structures who are affected and entitled to compensation. We're 100% behind that. But do you ever foresee a day where, once we've dealt with all of those, we will find ourselves in a situation where the mines are running optimally and safely enough that these kind of diseases are going to be a thing of the past?
Thank you, Chairperson. Thank you for the presentation. And yes, there has been a very good improvement, and we see that from you guys year on year. And the electronic system that's been put in place is really impressive. I mean, that's what we want to see, advancement within our departments. Firstly, I'd like to find out, how will the outstanding claims of over R1 billion, the old historic claims, how would you address that? And then my colleague has addressed the underspending, which I will leave to you to answer, because in terms of the PFMA, your expenditure level should be at around 95%. Then I also just wanted some clarity. When will the vacancies be filled? And why has, sorry, I've got, that's the wrong question, sorry. Just ignore that question. I'm looking at another set of notes. Just regarding the submission of amendments to the Occupational Disease in Mines and Works Act, where is the CCOD in this process? I know you said that, you had finalized the bill, and obviously because there is a long list of bills that still have to come to Parliament, and this bill will obviously not serve in this term. Would this question form part of the bill to be processed? If you can just give me clarity on that. And how many specialized personnel does the CCOD require? And when will this be addressed? How much of the budget is prioritized for communication and education to inform minors and their families of the rights, and from which programs budget would this come from? How does the CCOD assist minors that inadvertently worked at uncontrolled mines? And please explain the naught compensation of TB, if you could give me feedback on that. And does the CCOD have an MOU with Chimasu Trust? And what is the assessment backlog on that? Thank you very much.
Honorable Chairman.
Thank you very much, Chairperson. Sorry about that. Thank you to the CCOD for their presentation as well. I wanted to ask about, because I remember in the previous years, we've had conversations about mines that don't pay levies to the CCOD, or that they pay late, or do not follow through with what they are meant to do. I want to find out if that issue is still persisting. And if it is, can we have the names of those mines? And secondly, I want to find out how do you guys go about deciding the value of a claim? What's the system that's in place, especially of claimants under the age of 50? Is life expectancy levels taken into consideration, and survival for longer periods? Are the dependents of the said claimants taken, or the number of the dependents of said claimants taken into consideration, and their personal needs? And because I really feel like the value system of the CCOD must be expanded and bettered as the years go by. That takes into consideration different aspects of survival, because as we grow and expand, I mean, that is across the board generally. We always have to better ways in how we respond to such issues, because it can't remain unchanged and redundant, because people's issues and needs and requirements change and evolve with time. And over and above monetary claims, are there medical interventions that are sorry about that, that are recommended or instituted by the entity for the affected persons? And lastly, I want to know if there's any known cases by the CCOD or to the CCOD of claimants ever being scammed, either by people that are assisting them with the claiming process, and what kind of relationship the CCOD establishes with those kinds of bodies, or it is limited to what about Siamisa. Siamisa, I don't know if I'm saying it correctly. Siamisa, yes. And if there's others, but I want to know of any known cases of such things occurring to the claimants, and how the CCOD handles those. Thank you very much, Chairperson.
Thank you very much, honorable members. Honorable Dr. Kisna Sami, just a few points for noting from me. One is, and it's been raised, this issue of the closed mines, and we have spoken about it. The fact that this is actually ongoing, those certificates which you need of the closed mines. And I will ask a question later with regards to all of these things, all of the issues which I will talk about. So that is the one, the certification of those closed mines. The second one is just to commend you on your active mine worker database. It is a huge improvement. At least you're able to find most of the people, I would guess, at this point in time, but I think there's still a lot of outstanding work to find everybody else. And also for them to be able to, for yourself to be able to follow your own process in terms of the medical examinations, the certification, the verification, and then to ensure yourselves that this person is actually a claimant in terms of the act and the mandate that you have. And then the electronic health records, we're looking forward to it also, in the same way as we have now seen your active mine worker database. We're looking forward to surely also maybe in other departments itself, once you health system really working very hard in this. I think I should ask you. Now, we know that mentioned by the members, the people, and and that process involves many other things, like it having to be taken to cabinet, the minister must sign off, etc., etc. So I think you probably, well, not think, I know you are correct that that will not be brought to Parliament within the 6th term, but we're really looking forward to it also as committee members, so that we can see in the future what you've been able to bring to South Africa in terms of the creation of the Section 3A entity. We want to congratulate you on that. The question I actually want to ask is, how can we as a committee assist you in this next few months to be able to speed up all of these processes, wherever your challenges and hiccups are, if you are able to maybe answer in terms of all of the issues and all of the points which were raised by all of the members, and specifically the points which I had raised. Thank you very much. And also to your team who came to present, we appreciate it. Thank you. Over to you, Dr. Kisnesan.
Thanks, Chair, and thanks to the members, and thanks to the colleagues who have presented. There were some overlapping questions, but let me just try and go as best as I can, Chair, to the members. And thanks for the comments in general from the members, which were positive. I mean, we're not out of the woods yet. I mean, it's a difficult task for a system that collapsed, as I pointed out before to this committee and previous committees, that the system for the mine workers program collapsed in 1973, when the system was opened up from 1912 to 1973, and then from 1973 took in all mine workers, as opposed to previously just catering for one race group. So the system, really we had to work, and if it were not for the partnerships and the support of your committee, we would not be where we are today. So thanks for that. So Honorable Gela, in terms of the plans, we are moving. We've got about 11 vacancies. Of course, these are administrative posts. The CCOD has built historically on administrative posts, and then there was the comment made by Honorable Clark about the specialized personnel. When we talk about the specialized personnel, these are information technology personnel, financial management personnel. I mean, I was gobsmacked to come in 2012, after the disclaimers. And of course, the previous commissioner was a chartered accountant, so at least there was some tools on financial management. But it was amazing that this fund, which at that stage was 2.8 billion, was not run, in terms of competent financial management skills. And with the support of the Minerals Council South Africa, we have 5 chartered accountants physically in the building on hand, dealing with different aspects, and hence, the approach in terms of the Auditor General, in terms of the clean audit into the process, because we've got a payment side and we've got a revenue side. So these 11 posts that we're talking about are administrative posts. They mainly help with the claims administration when a certification committee sits with medical doctors, with Dr. Machali, or checking on bank account details, which we've now done online bank verification, etc. So we're also upskilling staff. Those processes are in place right now to fill these posts, and we are in discussion through Dr. Anbin Pillay. Fortunately, we've had very strong support since he's been back at ABX as the cluster manager, branch manager in terms of this work. So we are hoping that we would get most of these posts filled later this year. In terms of the Register of Mines and Works, that's an ongoing. So that's the first tick box, Chair, about when will you convene a meeting of the 2 portfolio committees, Mineral Resources and ourselves, because there's quite a few things we need from Mineral Resources. One is the completeness of the Register of Mines and Works. Remember, Mineral Resources provides the licenses for mines, and Department of Employment and Labor provides the licenses for smelters and refineries. So we need a meeting of the 3 portfolio committees, because we have tried through departmental interventions to meet with the officials in the different, and I'm not too sure whether, we do get some registers, some are electronic, and this is something that probably we could do, because if you want a completeness of the register, then part of the process is to work with the departments that do the licensing and inputs. We don't give licenses. We are there only to go and collect. In terms of the process with the Odimwa reform, that's one of the issues that we've highlighted, that we will have our own register that would be generated through a process in terms of Odimwa and pulling that together. So we can't say for sure that we have a complete register, but Auditor General has accepted that we've done the best we could in terms of the inspections, of trying to get closure certificates, and mine closure certificates, I'm told, take a long time, partly because of the rehabilitation that has to be done, etc. And that also links up to the liquidation question by Honorable Wilson. At least we are on top of that, and that's one of the issues that I've raised, is that the urgency. My act makes provision for a mine to tell us if they alienate, sell, close a mine, or dispose of the mine, they ought to get a certificate of good standing. We're going to start imposing that from this year onwards, in a sense of, firstly, we are preparing a electronic register of all mine workers at a mine and a works. And part of that process will be to re-emphasize the issue around the fact that if they liquidate, etc., they ought to let us know. So we're going to discuss that with the Department of Mineral Resources as well. But part of that issue is that we're going to get this electronic register of current workers. The master database that we demonstrated was the legacy project that we were working on in terms of that process. So part of the issue is the liquidation. Yes, we're on top of that. We've already sent notices to 2 mines which are in business rescue, to see that we are a creditor with that. Unfortunately, there were previous mines that have gone into business rescue, which unfortunately we couldn't be part of. But right now we're on top of this process. And one of the issues is to meet with the Department of Mineral Resources and Energy. And it's something that we could discuss in terms of the joint portfolio committee year meetings. And secondly, we also need health records from closed mines. One of the big issues, Dr. Jacobs, on the digitization project is we are digitizing our records that are currently in Metrofile, the 1.2 million records, of which about 600,000 are active. And that was funded by a special grant from Rand Mutual. Thanks to Rand Mutual for that special grant to Metrofile for the digitization project. But this is a much bigger project in terms of getting ex-mine worker records from mining companies that have closed. And it's something, again, we'll have to pursue outside of this meeting in terms of the joint working. On the issue of the the specialized personnel which are raised by both Honorable Geller as well as Honorable Clark. I mentioned it's information technology specialists, it's the database management specialist, financial management, and it's the medical specialists. We haven't been able to recruit medical specialists. One, we don't have the posts in terms of occupational health. I mean, I have a medical background, but it need not necessarily be that the commissioner is a medical person. And I, of course, can actually work on both sides of the fence and be fortunate that we have seconded and professional staff that have been supported by the Minerals Council, like Dr. Rabada, Dr. Mitchali, and Dr. Burtis, who have done heavy lifting in terms of the support they give us in terms of the work that they do. So it's this level of support that we needed in terms of some of the specialized staff. And that in terms of the new organogram will be developed when the Odomwa bill passes through the different phases. And then of course we'll create a new organogram with the necessary levy. On the amendments to Odomwa, which was raised by 2 or 3 members, yes, Chair, you know the
Commissioner,
Yes.
can I ask somebody called Thomas to please switch off your camera, people walking past in your background? That's all. A person called Thomas must be part of your team, Commissioner. Thank you. Continue.
Thanks, sir. So in terms of the amendments to Dimwa, your committee is actively, is the legislative arm and takes forward the process through Parliament. So what we've done, we've got a completed bill. We had to get certification by State Law Advisor, which we completed the comments to State Law Advisor 2 weeks ago, but we're due to meet State Law Advisor. We then, once we get the certificate from the State Law Advisor, we'll then take it to the social cluster of Director Generals, of which we are part of, then to the Forum of Director Generals, and then to the Cabinet Subcommittee. So this process is probably going to take us the better part of another year in terms of getting it through all those hoops. So hence, it is a fairly elaborate technical process. We have done the socioeconomic impact assessment. So those parallel documents are all ready. The only issue was State Law Advisor giving us the certificate of compliance in terms of activities and thereafter going through some of the technical administrative processes before it actually comes through the parliamentary process. So unfortunately, it's going to take us time, but it is a substantive redraft of the bill. It's called the Mines and Works Compensation Bill, brings on board a new authority, sets out the new levy framework, sets out service delivery. I mean, members will recall that the 1973 Act excluded Transkei, Botswana, Venda, and Ciskei from being part of the service provision. It never even considered Mozambique, Lesotho, etc. So major flaws in the current bill that we needed to sort out. So that's unfortunately going to take time in terms of the process. The MOU with Minerals Council is in place. It starts in 2020. It continues up to the end of this year by amendments signed off by the Director General and has been also made available to the Auditor General and internal audit in terms of it governs how the monies are spent. There's no physical money that exchanges hands. The Minerals Council pays directly to the service providers, the financial management team, the information management team, the seconded and professional staff, and the mining companies that help together with the outreach activities, etc. Decentralized offices, this is a problem. We are hoping, Honorable Geller, that the constituency offices, again, Chair, when you asked about how could the portfolio committee help, so one is the master database will be made available to yourselves. You'll get authorized access, and if your constituency officers, if there's an ex-mine workers, they could come in and look up, and you could update that, and then we could contact them in terms of getting the claims put in, etc. So one of the processes was to also the MOU that was raised with the Shia Misa Trust in terms of Honorable Clark had raised. We do also have an MOU and a data sharing agreement with the Shia Misa Trust, and we're working quite closely together in terms of the outreach activities and trying to dovetail some of the operational activities so that we can work closely with them. Linked to that is, I think, Chair, you are going to be convening a meeting of the different class action lawsuits, settlement trusts. Some of them are in the closing phases, but some of them do have time that they will be moving on. They have some time left. One of the issues, of course, we do need is also the electronic dump of their medical records, etc., similar to the mining companies, etc., so that we could actually start getting a comprehensive picture of an ex-mine worker than the current mine worker. And this links to the issue around decentralized services. It's very expensive to run decentralized services, and hence we've tried for the one-stop service outreaches like the one that's taking place in the Eastern Cape right now. And we've got the 4 one-stop service centers, which are barely sustainable. We have made application to National Treasury for some additional funds. There's some discussions taking place between our minister and the Minister of Finance, Minister of Labor, Employment and Labor, in terms of some discussions about how we can actually fund these decentralized service delivery processes, apart from the mining companies helping. Honorable Clerk, we do appreciate the fact that we are saying there's not enough funds, but when the funds are provided, we are not spending. The goods and services was related to procurement of service personnel, service providers that can actually provide the decentralized services, and both within South Africa and in neighboring countries. And it was quite an elaborate process. Remember, 1/3 of the ex-mine workers come from neighboring countries. And in order to procure service providers in those countries, we had to go through an elaborate process. Dr. Machali is in the final stages of concluding that with our supply chain. And that was part of the reason why about 30% of the funds were not spent on the goods and services was related to that. It's the transportation of the hearts and lungs. It's the, you remember, we have a special program with the National Institute for Occupational Health. It's the prosector services, and it's the clinical services that have to be rendered, particularly in labor sending areas and neighboring countries. So that was quite an elaborate program that unfortunately it was very difficult to work out the supply chain management processes, especially that of neighboring countries. On the capital, again, that was related to a procurement process that we were stuck with in terms of computer equipment and hardware. And we are hoping to get that resolved again this year. But we note that that is a problem where we don't have enough funds, but at the same time are underspending. The surpluses, well, in terms of voted funds, we cannot retain surplus, I mean, unless the funds are committed. So we will ask for rollovers on that. But the surplus funds in the fund does not go back to National Treasury. We, of course, we now have to discuss, we were an unlisted public entity up to the 28th of March. We are in discussions with National Treasury. There's a meeting to be convened next week with National Treasury about the implications for the listed Mines and Works Fund, and whether some of these discussions in terms of what we're calling a surplus, but it's actually a valuation process in terms of supporting the now 5.4 billion compensation fund. So we'll be able to feed back in terms of the current PFMA processes and the listed entity after the meeting next week. I touched base, Honorable Wilson, about the liquidation processes, that we're on top of that, but it will also be a meeting agenda point if it's a joint portfolio committee meeting, and the vacant posts I also covered. On the issue of prevention, you raise an important point. I mean, we should not be in the business. We should not have a CCOD and an MBOD in the real world. We should not be having a QIDA fund in the real world. But unfortunately, these things do happen, and I must congratulate the mining industry. I think the TB rates have now halved. We were very tough on the mining industry when I took up my office in 2012. The rates for TB were tremendously high. Dr. Matsuleri led the team. We had tremendous inputs, and through a project called Program Masohisa, the mining company now, the rates for TB in the mines is half that of the community rates. It's running at about 200 per 100,000 compared to the 500 per 100,000 or 600 per 100,000 community rates. On the silicosis, asbestosis, of course, we don't have asbestos mines, so it's a legacy process. Coal workers pneumoconiosis, there's been milestones set by the summits through Department of Mineral Resource and Energy. And again, many of these dust level control, many of the colleagues around the table, the occupational hygiene team and the risk committee team members have been very active with the mining companies in terms of the prevention aspects. So we must congratulate them that the prevention aspects are coming in, notwithstanding the training of the health professionals. Honorable Clerk, on the historic... All right. On the historic claims, the bulk of these claims, Honorable Clerk, are before 80% are before the year 2000. So we have a special program that we're going to set up in terms of reaching that. We think many of these claimants are deceased. We'll have to go back on health records, and that's why we'd have to talk to how we get further funds in terms of the digitization project, which is proving to be a success. Because notwithstanding the health records for mining companies that have closed, we also have to look at health records from the TBVC states, TB records within the NHLS, and maybe that's one of the things you could raise, because we've been having difficulty. I must have say we have a breakthrough, Chairperson, that the POPI regulator, the information regulator, has given me a blanket approval for database access, and we can share that with your committee later today in terms of accessing databases to go after these historic claims. So that's a special program. We are working with the Ex-Mine Workers Association, neighboring country and provincial governments, and part of that process today of the outreach activity in the Eastern Cape, in Kweleni, Lebode, and Kobo, is actually to try and reduce these historic claims. I talked about the specialized personnel, communication, education. Unfortunately, Honorable Clerk, we don't have a budget for that. We do have some support transversely from the National Department of Health Comms and Comms grouping, and we are working with the Shiamiso Trust, the Class Action Settlement Trust, and there's some support that we get from the Minerals Council. We do have a call center supported by the Minerals Council, and for example, the activity in the Eastern Cape is led by the Office of the Premier, and GCIS also assisted with that approach. Uncontrolled mines, it's going to be a long story. It's a discussion again, agenda item for the Department of Mineral Resource and Energy, as well as Rand Mutual and Department of Employment and Labor. This is a gray area. Every mine worker, whether controlled or not controlled, is entitled to a benefit medical examination, but the payment of compensation can only come from the compensation fund if the mine is controlled. So the key area here has been a dislocation in discussion between ourselves and Rand Mutual about who will pay for this uncontrolled mines and a mine worker from that. So that's a special agenda item, and it is a problem at the moment, and we have not managed to control any more mines. So there's a large 2,400 entities we are told are registered with Department of Mineral Resources, of which only 219 are actively paying to us. So that's a different discussion. I talked about the MOU. TB claims, I couldn't get that, Honorable Clerk. I could take that offline with you. Honorable Chirwa, the mines that don't pay levies, we are working through that, and I could probably discuss with the chairperson about how to deal with that. We are discussing with the Minerals Council about that as well. As I pointed out, there is one mine at the moment where we have taken legal action against in terms of collecting levies. Value of a claim is a problem, hence we've had the class action lawsuits. We currently have a first degree and a second degree model, and it's based on an actuarial valuation and an historical basis of wage claims. So it doesn't take into account social circumstances, numbers of families, life expectancy, and the only issue is the impairment rating, first degree or second degree. And unfortunately, that was why we had the class action settlements and why Odemwa reform is needed. And we'd value some inputs from yourself in terms of that. On the medical interventions, Dr. Machali tries if it's an active mine worker or an ex-mine worker where we can trace the medical company, we can then reach out to them, and some of them are present around the table where they've provided some support for the medical interventions. Of course, the Shiamiso Trust, Quebeca Trust, and other Asbestos Relief and Kolakadi Trust, which Chairperson I'm sure will convene a meeting, do provide some medical relief support. Unfortunately, our fund doesn't provide medical relief support. It's another deficiency in Odemwa. On fraud, there were 16 syndicates operating into my office. 3 cases are registered with SAPS. 1 is currently being prosecuted by the Hawks and the National Prosecution Authority. It's seen the light of day finally in the Palm Ridge Magistrates Court in terms of a syndicate that was operating in Polokwane. Thanks, Chair. Over. Of course, I didn't mention yours, Chair, that you, but I think I covered some of it. And thanks for your comments on the digitized health records and the master database and some of the inputs on how the committee can assist. Thanks, Chair. Back to you.
Thank you very much, Dr. Kisnasamy. What a broad reply. We appreciate it. I'm going to ask you to do something for me. You have a long list of manners in which the portfolio committee can assist you. If you can please send that in a written format to me, to our committee secretary, and also with the requests which you want to raise. Please write formally. You know Ms. Majalamba very well, and I'm looking forward to your writing, and we will then act upon, if we deem it fit, what you request. Thank you very much. Last 30 seconds for you, Dr. Kisnasamy.
Chair, just to appreciate the support of your committee under a very difficult period, and looking forward to further engagement, hopefully in the new administration with the Odumwa reform, and hopefully with your constituency officers multi-party. We'd like to work closely with you all. And thanks to my colleagues and many of the guests that you've admitted who work with us as partners to deliver a better service to the people who help to build the economy of Sandton. Thanks, Chair. Over.
Thank you. Please have a good day. You're welcome to leave. If you want to listen to any of the other presentations, you're also welcome to do that. Honorable members, we're going to take our lunch and tea time at once, which should be now, between now and 1500 hours. So please do not switch off your devices. Enjoy your lunch. We will have OHSC at 1500 hours, and then we should be able to complete our work by 16:30. Thank you very much.
Thank you, Chair and members. Goodbye.
Goodbye.